Shock is a life-threatening condition that occurs when inadequate tissue perfusion and oxygen delivery leads to end organ damage and potentially death. Now, the four types of shock include distributive, hypovolemic, cardiogenic, and obstructive. Distributive shock occurs in the setting of excessive systemic vasodilation, leading to impaired blood flow distribution. Next up, hypovolemic shock occurs due to a critical loss of fluid volume. Cardiogenic shock results from a compromise of myocardial performance, leading to a severely decreased cardiac output. Finally, obstructive shock results from obstruction of blood flow from either filling the heart or ejecting into the great vessels, which also ultimately leads to a decreased cardiac output. Now, patients presenting with signs and symptoms of shock will be unstable, so immediately perform an ABCDE assessment and begin acute management. Start by stabilizing their airway, breathing, and circulation. This means that you might need to intubate the patient. Next, obtain IV access and consider giving IV fluids, as well as placing a central venous catheter for administration of medications and hemodynamic monitoring. Additionally, you can insert an arterial catheter for continuous monitoring of the mean arterial pressure, or MAP. Occasionally, you may also place a pulmonary artery catheter, or PAC, to measure certain hemodynamic parameters. Finally, put the patient on continuous vital sign monitoring, including heart rate, pulse oximetry, and blood pressure. Okay, now that you've initiated acute management, it's important to obtain a focused history and physical, as well as order lab tests. Patients may describe generalized weakness, fatigue, lethargy, and postural dizziness. Physical exam typically reveals hypotension and weak peripheral pulses, as well as tachycardia and possibly altered mental status. At this point, you can suspect shock, so your next step is to assess the patient's skin temperature as well as capillary refill time, or CRT. CRT is an indicator of perfusion and is done by squeezing the patient's digit until it blanches, then releasing the pressure and recording the time it takes to go back to its normal color. Normally, this takes 2 seconds or less. Anything longer may be an indicator of poor perfusion due to impaired cardiac output. So, if you notice warm, dry, flushed skin, you should immediately consider distributive shock. In addition, these patients may have a normal CRT. The different causes of distributive shock include sepsis, anaphylaxis, or neurologic injury. First, let's start with septic shock. These patients typically present with fever and symptoms suggestive of a source of infection, such as flank pain. Physical exam might also reveal signs of a source of infection, like costovertebral tenderness, while labs could demonstrate leukocytosis and thrombocytopenia, as well as elevated lactate and inflammatory markers like ESR, CRP, and procalcitonin. These findings should make you consider septic shock, so order blood cultures and imaging like X-ray and CT. If blood cultures are positive and imaging reveals a source of infection, this supports the diagnosis of septic shock. Here's a high-yield fact. Management includes fluid resuscitation, broad-spectrum antibiotics, and vasopressors like norepinephrine or dopamine. Now, here's a clinical pearl to keep in mind. If your patient presents with hypotension, warm skin, and normal CRT in combination with fever, flank pain, and costovertebral tenderness, think of septic shock due to pyelonephritis. Another type is anaphylactic shock. In this case, history typically reveals exposure to a known or suspected allergic trigger, such as food, insect stings, or bites. Important physical exam findings include urticaria and itchy skin, as well as labored breathing, wheezing, and stridor due to airway edema. In these individuals, you should consider anaphylactic shock, so you can order tryptase, which, if elevated, will help confirm the diagnosis of anaphylactic shock. However, keep in mind that tryptase won't peak until 1 to 1.5 hours after the onset of symptoms. As a high-yield fact, management includes immediately removing the allergic trigger and giving intramuscular epinephrine. The least common type of distributive shock is neurogenic shock. History generally reveals brain or high-level spinal cord injury or trauma. In contrast to other types of shock that compensate for low cardiac output by increasing the heart rate, in patients with neurogenic shock, you may see a paradoxical bradycardia due to disruption of autonomic tracts. Additionally, the physical exam might reveal neurologic deficits such as paresis and paralysis. All of these findings should make you consider neurogenic shock, so immediately order a CT scan which may reveal a skull or vertebral fracture, cerebrovascular accident, as well as spinal cord injury. Positive image findings from the CT will support the diagnosis of neurogenic shock. Now let's look at hypovolemic shock, which is characterized by a decrease in intravascular blood volume to a point where tissue perfusion can't be adequately maintained. So, if you notice cold, clammy skin and delayed CRT, then assess your patient for evidence of volume loss. If you see evidence, like from blood loss or dehydration, then consider hypovolemic shock. Hypovolemic shock can be further classified as hemorrhagic or non-hemorrhagic. First, let's start with patients that present with history suggesting a bleeding source, most commonly due to trauma or blood loss from the gastrointestinal or genitourinary tracts. These individuals often present with hematemesis, melena, or hematochezia, but sometimes there might be no visible sign of bleeding. Additionally, CBC reveals low hemoglobin, which helps confirm blood loss. At this point, you should consider hemorrhagic shock. So, your next step is to order imaging methods like ultrasound and CT, as well as diagnostic procedures such as EGD or colonoscopy to visualize the bleeding source, which, if found, supports the diagnosis of hemorrhagic shock. Now, let's take a look at non-hemorrhagic shock. These individuals report a history of vomiting, diarrhea, or burns. In this case, physical exam often reveals decreased skin turgor, dry mucous membranes, as well as decreased urine output. Additionally, CBC reveals high hemoglobin, which suggests hemoconcentration. These patients should make you think of non-hemorrhagic shock. So, the next step is to assess each organ system for the cause of fluid loss. In patients who describe excessive diarrhea or vomiting, think of gastrointestinal causes like irritable bowel syndrome or GI infection. On the other hand, if your patient presents with severe blistering or eschar formation, consider burn injury. Either of these will support the diagnosis of non-hemorrhagic shock. Here's a high-yield fact. Management of hypovolemic shock includes addressing the underlying cause, while also giving IV fluids, or even blood transfusions if needed. Keep in mind that vasopressors are typically not recommended here, since they can further decrease tissue perfusion. Okay, let's go over the last two categories of shock, starting with cardiogenic shock. When treating patients that have cold, clammy skin and delayed CRT with no evidence of blood or fluid loss, you should consider either cardiogenic or obstructive shock. So, if you suspect cardiogenic shock, you should immediately order labs, including cardiac enzymes and BNP, ECG, and imaging such as transthoracic echocardiography, or TTE for short. These diagnostic methods will help you differentiate between the most common causes of cardiogenic shock: heart failure and myocardial infarction. Let's start with heart failure. These individuals usually report shortness of breath and fatigue. Physical exam often reveals signs of volume overload, such as peripheral edema, crackles, and jugular venous distension, but keep in mind that some patients can also occasionally present without volume overload. Laboratory studies will typically show an elevated BNP, while a TTE might demonstrate systolic or diastolic dysfunction, structural changes, or valvular incompetence. With these findings, you can have confidence that the diagnosis is heart failure. Another important cause is myocardial infarction. These patients typically report a squeezing substernal chest pain that radiates to the arm and might be diaphoretic on a physical exam. Additionally, ECG findings can include ST elevations, while labs reveal elevated cardiac enzymes, which confirm the diagnosis of myocardial infarction. Now, let's go back to obstructive shock. So, if you suspect obstructive shock, history and physical should point to the most likely underlying cause and guide your next steps in management, such as labs or imaging. These diagnostic methods will help you differentiate between the most common causes of obstructive shock, such as pulmonary embolism, cardiac tamponade, and tension pneumothorax. First, let's start with pulmonary embolism, which is typically associated with pleuritic chest pain, hemoptysis, and a history of DVT. Physical exam findings usually include tachypnea as well as unilateral leg swelling, while labs might reveal a high D-dimer level. In these patients, use Wells criteria and imaging, primarily CTPA, to diagnose pulmonary embolism. Moreover, Wells score above 2 and filling defects on CTPA confirm the diagnosis of pulmonary embolism. On the other hand, in cardiac tamponade, individuals usually report chest pain that's relieved by sitting up and leaning forward. The classic physical findings, known as the Beck triad, include hypotension, jugular venous distension, and muffled heart sounds. Chest X-ray might reveal a widened mediastinum and a water bottle sign, where the cardiac silhouette appears enlarged and stretched. Diagnosis of cardiac tamponade can be confirmed via echocardiogram, which typically shows pericardial effusion as well as the diastolic collapse of the right atrium and ventricle. Finally, let's look at tension pneumothorax, which is associated with the history of sudden and severe chest pain and shortness of breath, as well as physical exam findings, such as shallow breathing, tachypnea, absent breath sounds on the affected side, and tracheal deviation toward the opposite side. Remember that tension pneumothorax is a clinical diagnosis based on history and physical, so it doesn't need further testing. Here's a clinical pearl. If you suspect tension pneumothorax, proceed with emergent needle decompression to release trapped air from the chest cavity. Once released, the patient's general condition will immediately improve. This confirms the diagnosis of tension pneumothorax. Sometimes, you can order a chest X-ray to detect a visible visceral pleural edge with absent distal lung markings on the affected side, as well as tracheal deviation and mediastinal shift toward the opposite side. Now, one last high-yield fact. While not routinely used in clinical practice, placement of a pulmonary artery catheter, or PAC, can be useful in the differentiation of one type of shock from another, as well as help guide hemodynamic resuscitation efforts, like the rate of IV fluid infusion and the decision to use vasopressors or inotrope. PAC parameters commonly utilized include pulmonary capillary wedge pressure, or PCWP, which gives an indirect measure of left atrial pressure. Central venous pressure, or CVP, is a reflection of right atrial pressure. Systemic vascular resistance, or SVR, is the afterload, or the resistance to blood flow in the peripheral arteries. Cardiac index, or CI, indicates the cardiac output from the left ventricle. And finally, venous oxygen saturation, or SVO2, measures the oxygen saturation in venous blood. In cardiogenic shock, PAC values you'll see include an increased PCWP and CVP, increased SVR, and decreased CI and SVO2. In obstructive shock, PAC will reveal a decreased PCWP, except in tamponade, where PCWP can be paradoxically increased, as well as increased CVP, increased SVR, and decreased CI and SVO2. In hypovolemic shock, your PAC values will reveal a decreased PCWP and CVP, increased SVR, and decreased CI and SVO2. In distributive shock, your PAC values will reveal a decreased PCWP and CVP, decreased SVR, and increased CI and SVO2 in sepsis or anaphylaxis, but decreased CI and SVO2 in neurogenic shock. Also, keep in mind that there are minimally invasive and non-invasive hemodynamic monitoring devices that can be used as alternatives to PAC. Alright, as a quick recap. Shock is a life-threatening condition that needs to be diagnosed and treated quickly. Patients with shock are unstable and require airway support, IV fluid resuscitation, and vital sign monitoring. Once you suspect shock, assess the patient's skin temperature and CRT. Warm, dry, flushed skin and a normal CRT suggest distributive shock, such as septic, anaphylactic, and neurogenic shock. On the other hand, if you notice cold, clammy skin and delayed CRT, assess for evidence of volume loss. Volume loss is associated with hypovolemic shock, further classified as hemorrhagic or non-hemorrhagic. If there's no evidence of blood or fluid loss, think of cardiogenic shock, most commonly due to myocardial infarction and heart failure, or obstructive shock, which can occur due to pulmonary embolism, cardiac tamponade, and tension pneumothorax.
Acute coronary syndrome, or ACS, is one of the can't-miss diagnoses that must be ruled out when a patient presents with acute chest pain. ACS is caused by sudden decreased coronary blood flow, also known as cardiac ischemia. known as cardiac ischemia. The three types are ST elevation myocardial infarction, or STEMI, non-ST elevation myocardial infarction, or NSTEMI, and unstable angina, where the latter two are collectively referred to as non-ST elevation, or NSTEACS. STEMI results from complete acute blockage of a coronary artery, leading to a transmural infarct of the myocardial wall supplied by that artery. NSTEMI results from a supply and demand mismatch, leading to non-transmural subendocardial infarct. Lastly, unstable angina also results from a supply and demand mismatch, leading to myocardial ischemia, but hasn't yet caused infarction. The first step in approaching a patient with chest pain is to do an initial assessment with a focused history and physical examination, or H+P, along with a 12-lead ECG. Prompt ECG should be obtained within 10 minutes of hospital arrival and shouldn't be delayed by H+P. When chest pain is due to cardiac ischemia, it usually worsens with exertion, is not relieved with rest, and doesn't change with body positioning. Some patients may complain of chest discomfort, pressure, tightness, or burning-like sensation, as well as palpitations, dyspnea, diaphoresis, nausea and vomiting, dizziness, and syncope. Ischemic chest pain often radiates to other parts of the body, including the epigastrium, left shoulder and arm, neck, and lower jaw. Relevant medical history in patients with chest pain includes hypertension, dyslipidemia, diabetes, tobacco use, and a family history of myocardial infarctions. Physical examination findings in patients with ACS can be variable, since proximal blockages in large vessels result in more myocardial damage than distal blockages in smaller branches. If a large myocardial area is affected, it can lead to decreased cardiac output. As a result, physical examination may show signs of cardiogenic shock, such as hypotension, tachycardia, diaphoresis, cool extremities, and pale skin. In addition, some patients may have evidence of acute heart failure, which is characterized by jugular venous distension, crackles on lung auscultation, new S3 gallop, new or worsening murmur, orthopnea, and edema. If there's suspicion of ACS based on H+P, markers of myocardial injury like troponin should be obtained. Some high-yield facts to keep in mind. If a patient has a history of stable angina, changes in their presentation that may suggest ACS include chest pain at rest for more than 20 minutes at a time, new onset chest pain that greatly limits their physical activity, or a change from their baseline angina in terms of frequency, duration, or onset of chest pain with less exertion. Also, some patients, particularly both cis and trans females, older patients, and those with diabetes may present with dyspnea rather than chest pain. While performing the initial assessment, establish IV access and attach cardiac and oxygen saturation monitors. Then, start MONA. M is for morphine, which is administered IV to manage pain. O stands for oxygen supplementation, which might be needed to maintain the patient's O2 saturation above 90%. N is for nitrates, which can be administered sublingually or less commonly IV for vasodilation to improve blood flow to the myocardium. Lastly, A is for high-dose aspirin, which is 325 milligrams, and it's given for its antiplatelet properties to prevent complete thrombosis. In addition to MONA, also give a high-intensity statin, like high-dose atorvastatin to stabilize the plaque. Finally, give a beta blocker, like metoprolol, to decrease myocardial oxygen demand and decrease mortality. Okay, now that you've done the initial assessments and acute management, it's time to check the ECG results for STEMI. If ST segment elevation is seen in 2 contiguous leads, it confirms the diagnosis of STEMI. However, a left bundle branch block, or LBBB, can mask ST elevation, so the diagnosis can also be made if there's a new LBBB with a presentation consistent with ACS. LBBB typically presents as QRS longer than 120 milliseconds, a dominant S wave in V1, broad-notched R waves, and absent Q waves in the lateral leads, like V6. Once a STEMI diagnosis is made, get a cardiology consultation to help guide management steps. The primary goal of treatment should be to quickly reperfuse the ischemic tissue to limit myocardial necrosis. But first, additional medical therapy needs to be given as long as it does not delay starting reperfusion therapy. All patients should receive dual antiplatelet therapy, or DAPT, which includes adding an oral antiplatelet medication on top of the aspirin they have already received. Similarly, they should also receive an anticoagulant to reduce the risk of thrombosis-related ischemic events. Now, let's look at the options for reperfusion therapy. If it's been less than 12 hours since the symptoms started, reperfusion therapy can still help salvage the myocardial tissue without causing large-scale reperfusion injury. If it's available within 90 minutes after the patient made first medical contact, the treatment of choice is percutaneous coronary intervention, or PCI. Coronary angiography is done first to detect the number and degree of coronary artery blockage. Then, during the PCI, a balloon catheter is advanced past the blockage and inflated to expand the blocked artery, and a stent is left in place to keep it open. If PCI is not available within 90 minutes, fibrinolytics like TPA can be given to break down the clot in the coronary artery if there are no contraindications. If a STEMI is identified and it has been more than 12 hours since the symptoms started, there could be large areas of myocardial necrosis. When reperfused, damaged cells can generate free oxygen radicals that further damage the myocardium and trigger more inflammation. Thus, it's important to assess for evidence of ongoing ischemia. This is characterized by refractory chest pain, hemodynamic instability, dynamic ECG changes, and ventricular arrhythmias. If any of these signs is present, PCI could still be pursued to prevent further ischemic damage. If these are not present, the STEMI should be managed with continued medical therapy. Okay, now let's look at non-ST elevation acute coronary syndrome, or NSTE-ACS. On ECG, there is no ST elevation, and the initial ECG shows ST segment depressions, T-wave inversions, or pathological Q waves. This could be either NSTEMI or unstable angina. So the next step to differentiate these two is to measure troponin levels. In NSTEMI, there's an elevation in troponin that indicates myocardial infarction. In unstable angina, the ischemia is not severe enough to cause myocardial infarction, so there's no release of troponin. So if NSTEMI is identified, get a cardiology consultation and start dual antiplatelet therapy as well as an anticoagulant. Then, assess the patient for evidence of ongoing ischemic injury. If there's no evidence, the patient should continue medical therapy. On the other hand, if they do show evidence, they'll need urgent coronary angiography. Based on the findings, they can either get immediate PCI or coronary artery bypass surgery, also known as CABG. Some of the main indications for CABG include multivessel involvement or left main coronary artery disease. This is because CABG provides more complete revascularization and has better outcomes than PCI in these situations. Now, if troponin levels are normal, unstable angina is diagnosed. The patient should undergo early risk stratification. Some scores used clinically include the Thrombosis and Myocardial Infarction, or TIMI score, and the Global Registry of Acute Coronary Events, or GRACE score. Patients at high risk for adverse events should undergo angiography within 24 hours. If unstable angina is diagnosed, they should start antiplatelet and anticoagulants. Then PCI or CABG based on findings. Patients at low risk should undergo non-invasive stress testing. If the stress test is abnormal, coronary angiography is needed to confirm the diagnosis, followed by antiplatelet and anticoagulants, then PCI or CABG. If it's normal, alternate diagnoses should be considered. It's important to note that fibrinolysis is never indicated for NSTEMI and unstable angina. Finally, sometimes the ECG will be non-diagnostic. When the initial ECG shows no abnormalities, but the H&P still raises concern for ACS, it's important to repeat serial ECG and troponin to assess for any changes. If the ECGs and troponin remain negative after serial monitoring, non-invasive stress testing should be performed as the final step to rule out ACS. If this is normal, alternate diagnoses should be considered. Any abnormalities during serial ECG, troponin, or stress test should be followed up with angiography. Alright, as a quick recap, acute coronary syndrome presents with chest pain that's not relieved with rest and doesn't change with body positioning. The first step in approaching a patient with chest pain is to obtain focused H&P and a 12-lead ECG. While performing the initial assessment, start MONA, which stands for morphine, oxygen, nitrates, and aspirin, followed by a statin and a beta blocker. Once you have the ECG results, if there's ST elevation in 2 contiguous leads, it's a STEMI. If there's no ST elevation, measure troponin, which will be elevated in NSTEMI and normal in unstable angina. Patients should be assessed to choose appropriate treatment and get reperfusion therapy as soon as possible when appropriate.
Bradycardia is typically defined as a heart rate below 60 beats per minute, or BPM, although in some instances it can be considered below 50 BPM. Bradycardia may originate from physiologic changes in vagal tone, pathologic changes to the cardiac conduction system, infectious causes, or medication effects. The severity might range from completely asymptomatic to life-threatening, and based on 12-lead ECG findings, you can determine if the bradycardia is physiologic, or if it's due to sinus or sinoatrial or SA node dysfunction, or even atrioventricular or AV node dysfunction. Now, if a patient presents with bradycardia, you should first perform an ABCDE assessment to determine if they are unstable or stable. If they're unstable and there's a detectable pulse, follow the ACLS guidelines for bradycardia with a pulse. First, stabilize their airway, breathing, and circulation. Provide supplemental oxygen if they're hypoxemic to maintain oxygen saturation above 90%. Next, obtain IV access and put your patient on continuous vital sign monitoring, including heart rate, blood pressure, and pulse oximetry. Now, let's go back to the ABCDE assessment and discuss the approach to a stable patient. First, perform a focused history and physical examination. Your patient may report exercise intolerance, lightheadedness, or even syncope, and some patients may experience ischemic-type chest pain or nausea. Additionally, on a physical exam, cardiac auscultation and pulse palpation will reveal a slower than normal heart rate. Moreover, if the heart rate is below 60 beats per minute, you can diagnose bradycardia. Here's a clinical pearl. The typical definition of a normal heart rate is between 60 and 100 BPM. However, although technically anything below 60 BPM should be considered bradycardia, you may find it defined as below 50 BPM since most patients with a heart rate in the 50s are actually asymptomatic and require no treatment. Next, obtain a 12-lead electrocardiogram or ECG. If ECG reveals a regular rhythm, upright, and uniform P waves before each QRS complex, normal PR interval, and normal P wave morphology, you can diagnose sinus bradycardia. Now that you know that the slow heart rate is originating from the sinus node, first you should consider SA node dysfunction. Common causes of SA node dysfunction include sinus pause or sinoatrial exit block, chronotropic incompetence, or tachybrady syndrome. If the ECG demonstrates periods of sinus bradycardia interrupted by periods of electrical inactivity without P waves or QRS complexes, this suggests sinus pause or sinoatrial exit block. Moreover, this is the most common cause of sinus node dysfunction, which typically occurs due to age-related fibrosis of the SA node. Next, if your patient reports exercise intolerance, order an exercise stress test. If the heart rate fails to increase with exertion, you can diagnose chronotropic incompetence. Finally, if the sinus bradycardia observed at baseline is interrupted by periods of paroxysmal supraventricular tachycardia, suspect tachybrady syndrome, also known as sick sinus syndrome. Now, here's a clinical pearl to keep in mind. In some individuals, sinus bradycardia occurs only during sleep, but that does not mean it's benign. The apneic episodes associated with sleep apnea may result in hypoxia, which in turn causes bradycardia. If sleep apnea is suspected, you should order a polysomnogram to further evaluate. Now, if you're considering SA dysfunction and find that no SA node dysfunction is present, then your next step is to assess for physiologic and reversible cause of sinus bradycardia. These causes can be broadly categorized as neurogenic, cardiogenic, or metabolic. Let's begin with neurogenic causes. If the bradycardia is at rest, or in a highly conditioned athlete, it is likely a normal response to increased vagal tone and doesn't require further evaluation if there are no associated symptoms. Alternatively, if an individual has a history of syncope related to identifiable triggers, like putting on a tie, changing positions abruptly, or coughing, then perform ambulatory ECG monitoring. If episodes of bradycardia correlate with syncopal events, the diagnosis is neurally mediated bradycardia, such as carotid sinus hypersensitivity, vasovagal syncope, or cough micturition syndrome. Next, if your patient has a head injury, stroke, or other intracranial pathology that might be interrupting autonomic tracts involved in heart rate response, perform a physical exam and check for Cushing's triad, which includes a decreased heart rate along with a widened pulse pressure and irregular respirations. If present, suspect increased intracranial pressure as a possible cause of the bradycardia. Now, let's go over cardiogenic causes of bradycardia. Your patient may report chest pain, and the ECG will have ischemic changes in the inferior leads on the 12-lead ECG, such as 2, 3, and AVF. These leads reflect the right coronary artery, which supplies the SA node, so occlusion leading to acute myocardial ischemia here can cause bradycardia. Ischemic changes may include pathologic Q waves, ST segment deviations like elevation, and depression, or T-wave inversion. If there's elevation, you can diagnose a STEMI. On the other hand, if there's ST depression or no ST changes, you should confirm by checking a serum troponin level. Elevated troponin levels are highly suggestive of acute myocardial infarction, so you can diagnose an NSTEMI. Lastly, normal troponin levels would indicate myocardial ischemia without infarction, which is consistent with unstable angina. On the other hand, if your patient is taking a beta blocker, a calcium channel blocker, or digoxin, keep in mind that these medications are known to have negative chronotropic effects, and you are likely dealing with a medication-induced bradycardia. Lastly, let's go over metabolic causes of bradycardia. If your patient reports fatigue, weight gain, and cold intolerance, check a TSH and free T4. If the TSH is elevated and the free T4 is low, your patient has hypothyroidism. Next, if your patient is hypoxic, hypothermic, or hypoventilating, pacemaker activity of the SA node can be reduced, causing reversible physiologic bradycardia. Finally, if your patient reports palpitations and their 12-lead ECG reveals U waves or tall-peaked T waves, consider electrolyte imbalance and order a CMP. If the serum potassium is below the lower limit of normal or above the upper limit of normal, consider hypokalemia or hyperkalemia as the cause of bradycardia. All right, now that we've considered physiologic and reversible causes of sinus bradycardia, let's go back, revisit our 12-lead ECG, and discuss patients who have evidence of an atrioventricular block. The patients will have a prolonged PR interval, P waves that are not always followed by a QRS, or evidence of complete AV dissociation. If you see any of these findings, suspect an atrioventricular block, or AV block for short. If there's a prolonged PR interval that is greater than 200 milliseconds with P waves that precede each QRS complex, this is first-degree AV block. Alternatively, if there's progressive lengthening of the PR interval followed by a missing QRS complex, diagnose Mopitz type 1 second-degree AV block, which is also called Winky-Bach phenomenon. On the other hand, if there's an unpredictable pattern of non-conductive P waves, but the interval between P waves remains consistent, diagnose Mopitz type 2 second-degree AV block. Finally, if there's wide QRS complexes indicating ventricular origin with no relation to the P waves, there's complete AV dissociation, and you can diagnose third-degree or complete AV block. If this is the case, there will be a regular PP interval and a regular RR interval, but they will be different lengths, usually with the RR interval being the longer of the two. Now here's a high-yield fact. Lyme carditis, a manifestation of Lyme disease, commonly presents with AV nodal block, which can manifest as first, second, or third degree, and may even fluctuate in severity. Luckily, most cases have relatively mild symptoms, which are transient and improve with appropriate antibiotic treatment of the underlying infection. Other less common infectious and reversible causes of AV block include viral myocarditis, infective endocarditis, toxoplasmosis, and Chagas disease. And here's another clinical pearl to keep in mind. Much like the sinoatrial node, the atrioventricular node can be affected by physiologic and reversible causes of bradycardia. These also include increased vagal tone, as seen in athletes and young persons at rest, ischemia, like an inferior wall MI, as well as with the use of medications that slow cardiac conduction, like beta blockers. Additionally, electrolyte abnormalities like hypokalemia and hyperkalemia can also affect the atrioventricular node. Finally, some causes of AV nodal disease are irreversible, like cardiac sarcoidosis or cardiac amyloidosis, where pathologic fibrosis and protein deposition cause progressive destruction of the cardiac conduction system. All right, as a quick recap, when approaching a patient with bradycardia, first, perform the ABCDE assessment to determine if your patient is unstable or stable. If unstable with a detectable pulse, follow the ACLS guidelines for bradycardia with a pulse. On the other hand, if stable, obtain a 12-lead ECG. If ECG reveals a regular rhythm, upright and uniform P waves before each QRS complex, normal PR interval, and normal P wave morphology, diagnose sinus bradycardia and consider SA node dysfunction. Important conditions associated with SA node dysfunction include sinus pause or sinoatrial exit block, as well as chronotropic incompetence and tachybrady syndrome. However, if there's no SA node dysfunction, consider physiological and reversible causes, which can be neurogenic, cardiogenic, or metabolic. Neurogenic causes include increased vagal tone, neurally mediated bradycardia, and increased intracranial pressure. Cardiogenic causes include acute myocardial ischemia and medication-induced bradycardia. Metabolic causes include hypothyroidism, reversible physiologic bradycardia from hypoxia, hypothermia, or hypoventilation, and electrolyte abnormalities, primarily hypo and hyperkalemia. Lastly, if 12-lead ECG reveals a prolonged PR interval, P waves that are not always followed by a QRS, or evidence of complete AV dissociation, consider AV block, which can be further classified as first degree, second degree Mobitz 1 or 2, and finally third degree or complete AV block.
Tachycardia refers to a heart rate above 100 beats per minute, or BPM for short. Once identified, a 12-lead ECG can be used to determine if the tachycardia has a regular or irregular rhythm, and if the QRS complex is narrow or wide. Further examination of the ECG can reveal details that help identify which type of tachycardia is present. Here's a high-yield fact. The typical definition of a normal heart rate is between 60 and 100 beats per minute. However, although tachycardia is technically considered to be above 100 beats per minute, the SIRS criteria consider tachycardia to be above 90 beats per minute. Now, if a patient presents with signs or symptoms of tachycardia, first perform an ABCDE assessment to determine if they are unstable or stable. If they're unstable and a pulse is present, then follow the ACLS guidelines for tachycardia with a pulse. Next, stabilize their airway, breathing, and circulation. Provide supplemental oxygen, if hypoxemic, to maintain oxygen saturation above 90%. Next, obtain IV access and put your patient on continuous vital sign monitoring, including blood pressure, heart rate, and pulse oximetry. Then assess for signs and symptoms of unstable tachycardia, including heart rate above 150 beats per minute, hypotension, altered mental status, signs of shock, ischemic chest pain, or acute heart failure. If your patient has unstable tachycardia, perform immediate synchronized cardioversion. Now, let's go back to the ABCDE assessment and discuss stable patients. First, perform a focused history and physical examination. Individuals with tachycardia may report symptoms like palpitations, exercise intolerance, lightheadedness, or even syncope. Additionally, physical exam might reveal a rapid heart rate, and if it's over 100 beats per minute, you can diagnose stable tachycardia. Next, obtain a 12-lead ECG and assess the heart rhythm by evaluating the consistency of the intervals from one R wave to the next, which is the R to R interval. If the R to R interval is the same from beat to beat, this means that you're dealing with a regular rhythm. Let's deal with tachycardia with a regular rhythm. First, assess the QRS duration, which corresponds to the width of the QRS complex. If the QRS complex is narrow, meaning under 120 milliseconds, there's a narrow complex tachycardia. In other words, the pacing originates above the ventricles, which suggests you are dealing with supraventricular tachycardia, or SVT. Next, assess the atrial activity on the ECG. Typical sinus P waves that precede each QRS complex, which are upright in leads 1, 2, and AVF, are suggestive of sinus tachycardia, meaning it's originating from the sinoatrial or SA node. Now, go back to history and physical findings to determine the cause of sympathetic stimulation, which can be either physiologic or non-physiologic. First, let's start with physiologic stimulation. If your patient presents with physiologic stressors like pregnancy, anxiety, pain, or exercise, consider physiologic sinus tachycardia from a non-pathologic stressor. On the other hand, if an individual has evidence of acute illness like fever, dyspnea, or pallor, evaluate for pathologic conditions that can cause sinus tachycardia like infections, anemia, dehydration, or pulmonary embolism. In these patients, you should think of physiologic sinus tachycardia from a pathologic condition. Now, let's go back and take a look at non-physiologic causes of sympathetic stimulation. If the workup reveals no obvious physiologic cause, but the individual reports symptoms like palpitations, fatigue, or syncope, you should evaluate for heart rate changes related to posture. Check the patient's heart rate when they move from a supine to standing position. Once they stand up, if their heart rate increases by 30 beats per minute from baseline, or if it exceeds 120 beats per minute within 10 minutes, in the absence of postural hypotension, you can diagnose postural orthostatic tachycardia syndrome, or POTS for short. On the other hand, if the sinus tachycardia is symptomatic but unrelated to postural changes, you can diagnose inappropriate or non-physiologic sinus tachycardia. Now, let's go back to the ECG and take a look at focal atrial tachycardia. In some cases of supraventricular tachycardia, the atrial activity shows P waves that are abnormal in morphology or deflection, but they're consistent in appearance. This is focal atrial tachycardia, meaning the electrical impulse is coming from a spot in the atrium that's outside of the SA node. Now, let's take a look at atrioventricular nodal reentrant tachycardia. Suppose you can't see P waves at all, or if they're just before or after the QRS complex, diagnose typical atrioventricular nodal reentrant tachycardia, or typical AVNRT. This type of tachycardia occurs when there's a re-entry circuit within the AV node. Now, here's a clinical pearl to keep in mind. An individual presenting with typical AVNRT typically reports neck pounding, a symptom that occurs as the right atrium contracts against a closed tricuspid valve. On exam, you might see neck pulsations that can guide you toward the correct diagnosis. Once you suspect it, you can confirm the diagnosis and treat AVNRT simultaneously. Give IV adenosine or have the patient perform a vagal maneuver, such as the Valsalva. If the tachycardia abruptly terminates, this is highly suggestive of AVNRT. Let's take a look at orthodromic AVRT. If the ECG reveals P waves that always follow the QRS, suspect orthodromic atrioventricular reciprocating tachycardia, or orthodromic AVRT for short. In this form of supraventricular tachycardia, an electrical impulse travels down the AV node to the ventricle in the usual manner, but then returns back to the atrium through the accessory pathway located outside the AV node, creating a P wave that follows after the QRS. The QRS is narrow because the ventricles are depolarized normally through the fast-conducting His-Purkinje system. Now, here's a high-yield fact. Electrical signals conducted through an accessory pathway can cause the ventricles to contract earlier than normal, which is called pre-excitation. Accessory pathways also create a two-way re-entry circuit, which can facilitate arrhythmias. A classic example is Wolff-Parkinson-White syndrome, or WPW for short. In WPW, the resting ECG has distinct findings, including a short PR interval under 120 milliseconds, delta waves, and a QRS duration over 110 milliseconds. Now, let's say the ECG reveals atypical inverted P with a P-to-P interval indicating an atrial rate equal to or greater than 250 beats per minute. The P waves, also known as flutter waves, will have a negative sawtooth appearance in leads 2, 3, and AVF that conduct at a 2:1 or 3:1 ratio to the ventricles. These findings are highly suggestive of atrial flutter with a rapid ventricular response. Okay, let's switch gears and go back to the ECG to assess heart rhythm and then assess QRS duration. If the patient's rhythm is regular and the QRS complex is wide, meaning it's over or equal to 120 milliseconds, first assess the morphology of the QRS complexes. If QRS complexes appear the same and there's an AV dissociation, consider monomorphic ventricular tachycardia, or VTAC for short. Monomorphic VTAC is the most commonly seen wide complex tachycardia, which typically occurs in individuals with fibrosis of the conductive tissue from previous myocardial ischemia or infarction. Here's a clinical pearl to keep in mind. Remember our discussion of accessory pathways causing orthodromic conduction? Sometimes, when there's an accessory pathway between the atrium and ventricle, the electrical impulses move in an antidromic direction, looping from the atrium to the ventricle through the accessory pathway and back up to the atrium through the AV node. Just like in orthodromic conduction, this creates a re-entry circuit, maintaining the arrhythmia, but since ventricular excitation through the accessory pathway is slower than through the His-Purkinje system, the QRS is wide, and the tracing looks similar to monomorphic VTAC. On the other hand, the presence of a right or left bundle branch block can also slow spread of cardiac depolarization through the ventricular myocardium, which results in a wide QRS. This is known as aberrant conduction. When atrial activity is present, but a wide complex tachycardia is present, you can diagnose supraventricular tachycardia with aberrancy. Okay, now that we're done with tachycardia with a regular rhythm, let's go back and switch our focus to tachycardia with an irregular rhythm. Again, the first step is to assess the QRS duration. If the QRS is narrow, or under 120 milliseconds, assess the atrial activity on the ECG. If there are no obvious P waves and there's an irregular ventricular response, that's atrial fibrillation with a rapid ventricular response. On the other hand, if you see P waves that have 3 or more distinct morphologies, you're dealing with multifocal atrial tachycardia, or MAT for short. Here's a high-yield fact. MAT is often seen in pulmonary disease like COPD, coronary disease, and valvular heart disease, as well as hypomagnesemia and theophylline use. Management of the underlying condition will sometimes terminate MAT. Be sure to avoid beta blockers in patients with pulmonary disease. If the ECG shows an irregular rhythm with QRS complexes that are wide, meaning over 120 milliseconds, there's an irregular wide complex tachycardia. In this case, again assess the morphology of each QRS complex. If it's variable, that's polymorphic ventricular tachycardia, or polymorphic VTAC for short. Polymorphic VTAC is commonly caused by acute myocardial infarction or hypertrophic cardiomyopathy, so if you see it, make sure to evaluate for these conditions. If the wide QRS complex waxes and wanes in size in a sinusoidal pattern, diagnose torsade de pointe. Now, one last high-yield fact. Torsade de pointe is associated with a prolonged QT interval during sinus rhythm, which might be congenital, but also has many reversible causes, including bradycardia, medications like antiarrhythmics, erythromycin, pentamidine, phenothiazines, and haloperidol, or electrolyte abnormalities like hypokalemia and hypomagnesemia. In fact, IV magnesium is the treatment of choice. Alright, as a quick recap, when approaching a patient with tachycardia, first perform the ABCDE assessment to determine if your patient is unstable or stable. If unstable with a detectable pulse, follow the ACLS guidelines for tachycardia with a pulse. On the other hand, if stable, obtain a 12-lead ECG and assess the heart rhythm. In stable patients with regular rhythm, first assess the QRS duration. If the ECG reveals narrow QRS complexes, your next step is to assess the atrial activity to differentiate between the most important conditions. The first one is sinus tachycardia, which covers physiologic tachycardia from non-pathologic and pathologic causes, and non-physiologic tachycardia, such as postural orthostatic tachycardia syndrome and inappropriate sinus tachycardia. Other important conditions include focal atrial tachycardia, typical AVNRT, and orthodromic AVRT, as well as atrial flutter with rapid ventricular response. However, if there's a regular rhythm with wide QRS complexes, you should assess QRS morphology. In this case, you should think of monomorphic ventricular tachycardia and supraventricular tachycardia with aberrancy. On the other hand, if your patient presents with tachycardia with an irregular rhythm, again assess the QRS duration. If there's a narrow QRS complex, consider atrial fibrillation with a rapid ventricular response or multifocal atrial tachycardia. However, if your patient presents with wide QRS complexes, consider polymorphic ventricular tachycardia and torsade de pointe. Burns are injuries caused by heat, cold, friction, radiation, electricity, or chemical exposure. When significant heat is applied to the skin, either in the form of a hot liquid, solid object, or flame, this thermal energy can result in irreversible tissue destruction. Extensive tissue destruction, especially in burns larger than 40% of the total body surface area, or TBSA, can cause fluid loss and with it hypovolemic shock. Burns are classified based on the depth of injury into first, second, third, and fourth degree burns, as well as burns accompanied by smoke inhalation. When evaluating a patient with burns, your first step should be an ABCDE assessment to see if the patient is unstable or stable. If the patient is unstable, first stabilize their airway, breathing, and circulation. This means that you may need to intubate the patient, obtain IV access, and administer fluids before continuing with your assessment. Now let's move on to the stable patients. If your patient is stable, start with a focused history and physical examination. History reveals thermal injury and can identify the mechanism of injury, such as hot liquids, flames, or grease. The physical exam will vary depending on the depth of the burn. Some burns might be accompanied by smoke inhalation, so let's talk about that. History might reveal delayed extrication from a fire in an enclosed space. On physical examination, your patient may have facial burns, singed facial hair, wheezing, or stridor. They may also cough up carbonaceous material or soot. Once you suspect inhalation injury, you should obtain labs, including an ABG and carboxyhemoglobin level. Findings may include decreased PaO2 and oxygen saturation. However, ABG might be completely normal initially. When it comes to carboxyhemoglobin, in non-smokers with inhalation injury, it might increase over 3%. However, in smokers, these levels might be greater than 10% since they are chronically exposed to carbon monoxide from tobacco smoke. Next, order a chest X-ray. The initial chest X-ray can be normal. However, it is important to establish a baseline evaluation of the lungs. If your patient is intubated, you should also perform a bronchoscopy, which may show carbonaceous deposits, edema, and erythema throughout the airway. Other findings include bronchuria, or copious sputum, and bronchial obstruction. Mucosal sloughing typically appears later as bronchial inflammation worsens due to chemical byproducts in the inhaled smoke. Based on all these findings, you can diagnose inhalation injury. The next step is to start inpatient management. This includes administering high-flow oxygen to maintain oxygen saturations above 90%. If the patient develops drooling, wheezing, or stridor, or is unable to maintain oxygen saturations higher than 90%, they should be intubated if they aren't already. In an intubated patient, you can also perform serial bronchoscopies to monitor the progression of the injury and wash out any carbonaceous material within the lungs. Burns are classified based on the depth of injury into first, second, third, and fourth degree burns. Let's switch gears and talk about first-degree burns, also known as superficial because they involve only the epidermis. To remember first-degree burns, just imagine a sunburn. So, on physical exam, the skin is soft, it blanches when pressure is applied, and is typically painful. If you see this, then you are dealing with a first-degree burn. Once you diagnose a first-degree burn, you can treat them on an outpatient basis. Management includes wound care, like cleaning the burn with cool tap water and mild soap and applying topical analgesia, such as aloe vera, if needed. If they require additional pain management, acetaminophen is usually sufficient. Now, let's move on to second-degree burns, also called partial thickness burns since they extend into the dermis. On a physical exam, the involved skin is usually warm, soft, and erythematous, and there might be pain to palpation. The skin may blanch when pressure is applied, however, blistering is often present. Deep second-degree wounds are less painful since some nerve endings have been damaged. They also blanch less than superficial ones. Alright, let's switch gears and talk about third-degree burns. Third-degree burns, also called full-thickness burns, are deeper and extend to the subcutaneous fat. Patients usually report little or no pain due to significant nerve damage. On physical exam, the skin may appear white, brown, or charred, feel firm or leathery, and doesn't blanch with pressure. Lastly, let's talk about the most severe burn category, fourth-degree burns. In fourth-degree burns, there is little or no pain due to extensive tissue necrosis. On exam, the skin appears charred and the burn extends down to the muscle, tendon, or bone. Once you diagnose the second, third, and fourth-degree burn, calculate the TBSA to determine the treatment. The first method to calculate TBSA is the rule of nines, which assigns specific percentages to different body surfaces. In adults, the head represents 9%, the anterior chest and abdomen are 18%, the back is 18%, and the perineum is 1%. Each arm is 9%, while each leg is 18%. Another method is the Palmer method, which involves estimating the affected area based on the size of the patient's palm, which represents 0.5% of their BSA, or their hand, which represents 1% of their BSA. The last method, called the Lund and Browder chart, is the most accurate but lengthy method. Here you mark an outline of the burn on printed body diagrams, calculate the affected area in each region, and add all the areas to obtain the TBSA. Once you determine the TBSA for your patient, you should decide whether they meet the criteria for inpatient management and even transfer to a dedicated burn center. Comorbidities or immunocompromised state, multiple trauma, any partial thickness burn greater than 10% TBSA, any full thickness burn, any burns to the face, hands, perineum, feet, or over joints, and any circumferential burns are criteria for inpatient burn treatment. If the patient doesn't meet these criteria, you can start outpatient management. This is the case with partial thickness burns that are less than 10% TBSA. Outpatient management includes daily dressing changes and the application of topical antimicrobial agents such as bacitracin or silver sulfadiazine to deep partial thickness burns. Alright, if the patient meets the criteria, admit them to the hospital and order labs, including CBC and CMP. You may identify electrolyte abnormalities, especially in larger burns with TBSA greater than 20%. When it comes to management, the main goal is fluid resuscitation. If your patient's TBSA is 10 to 20%, start maintenance lactated Ringer solution to maintain urine output at 0.5 milliliters per kilogram per hour. If the TBSA is greater than 20%, use the Parkland formula to determine your patient's fluid deficit. The Parkland formula is as follows: 4 milliliters multiplied by percent TBSA multiplied by the patient's weight in kilograms. This will give you the total amount of crystalloid fluid needed in the first 24 hours, with half of the volume administered in the first 8 hours and the remaining amount given over the next 16 hours. Then administer lactated ringers to replace losses and maintain urine output at 0.5 milliliters per kilogram per hour. Remember that in patients with severe burns, exclusive use of crystalloid fluid may result in over-resuscitation, which can lead to complications like bowel and pulmonary edema. Next, you should initiate pain management with medications like acetaminophen, gabapentin, or narcotics. In intubated patients, you should also administer sedation. Now, always remember that burn patients are in a hypermetabolic state, meaning their bodies break down more protein. In terms of nutrition, burn patients have higher caloric and protein needs. If they can tolerate oral intake, start them on a high-protein diet. If they are intubated, initiate enteral nutrition and start prophylaxis to prevent stress ulcers. Here's a clinical pearl. Since burns are open wounds, be sure to monitor closely for signs of infection. For non-surgical management, topical antimicrobials like bacitracin, mupirocin, silver sulfadiazine, or mafenide can be applied prophylactically over the damaged skin, while the use of oral or IV antibiotics hasn't shown any proven benefit or improved outcomes. Additionally, if they are not up to date on their immunization, make sure to give them a vaccine or prophylaxis for tetanus. Alright, when it comes to surgical management, patients with partial thickness burns usually need wound debridement and sometimes skin grafting. Grafts for partial thickness burns include xenografts and synthetic dermal substitutes. Patients with full thickness burns will often require a different type of graft called an autograft, which uses the patient's own skin. Allografts, or skin from cadavers, may be used temporarily for deeper burns that can't be immediately staged. Now, if your patient has a circumferential burn, you might need to perform an emergency escharotomy. This involves making an incision through the burnt skin to release the eschar and restore circulation to the area, or in the case of a circumferential chest burn, to allow for adequate ventilation. Finally, fourth-degree burns that extend down to the bone might require amputation of the involved limb. Alright, as a quick recap, burns are classified depending on depth into first, second, third, and fourth degree, and some burns might be accompanied by smoke inhalation, causing inhalation injury to the airways. Treatment is based on the type of burn and the TBSA involvement. First and superficial second-degree burns are treated non-surgically with dressing changes and topical agents. Deep second-degree burns involving over 10% TBSA, third-degree and fourth-degree burns should be managed as inpatients. Administer fluid resuscitation with crystalloid, pain management, and nutritional support. Surgical treatment involves xenografting, allografting, or autografting. In the case of fourth-degree burns, amputation may be necessary if the burn extends to the bone.
Pneumothorax refers to an abnormal presence of air within the pleural space that can result in a deflated or collapsed lung. The pleural space has a parietal layer, which lines the chest wall, and a visceral layer which lines the parenchyma of the lung. Disruption of either of the pleural layers can allow air to enter the pleural space. This can occur spontaneously, usually due to rupture of anatomic lung defects called blebs and bulli, or traumatic, which might occur after a penetrating chest injury or even a medical procedure. Based on the underlying cause, pneumothorax can be classified as spontaneous pneumothorax, which is further subdivided into primary and secondary spontaneous pneumothorax, and non-spontaneous pneumothorax. Now, if you suspect pneumothorax, you should first perform an ABCDE assessment to determine if your patient is unstable or stable. If the patient is unstable, stabilize the airway, breathing, and circulation. This means that you'll need to assess the need for ventilatory support, and you might need to intubate the patient. Next, obtain IV access. Provide supplemental oxygen to maintain SaO2 above 92%, and put your patient on continuous vital sign monitoring such as pulse oximetry, blood pressure, and heart rate. Next, perform a focused history and physical and get a chest x-ray as soon as possible. Your patient might report sudden chest pain and shortness of breath, while your exam will reveal an asymmetric chest and tracheal deviation away from the affected side, as well as hypotension, respiratory distress, and decreased or absent breath sounds on the affected side. Keep in mind that tension pneumothorax is a clinical diagnosis and doesn't need further testing. However, if you were to perform a chest x-ray, it would show a distinct visceral pleural edge with an absence of lung markings distally, often with a depressed hemidiaphragm ipsilateral to the collapsed lung, known as a deep sulcus sign. In severe cases, you'd see shifting of the mediastinum contralateral to the collapsed lung. Okay, listen up. Here is a clinical pearl. Since tension pneumothorax is so dangerous, it should be diagnosed based on clinical suspicion, and treatment should not be delayed, even if imaging has not been performed or results are not yet available. In fact, you'll want to perform immediate decompression with needle thoracostomy. Identify the second intercostal space where it intersects with the midclavicular line. Then insert an angiocatheter through the chest wall just above the rib. If effective, you will release the trapped air, allowing the lung to reinflate and relieve any mediastinal compression. You will later need to proceed with tube thoracostomy or placement of a chest tube connected to continuous low-pressure suction to allow full reinflation and decrease chances of recurrence. Now, let's jump back to the ABCDE assessment and take a look at stable patients. If your patient is stable, proceed with a focused history and physical examination. Your patient is likely to report sudden onset of pleuritic chest pain, or pain that gets worse with deep breathing, as well as shortness of breath. Common examination findings include tachypnea, shallow breathing, and decreased or absent breath sounds on the affected side of the chest. If these findings are present, suspect pneumothorax and order a chest x-ray. Look for a visceral pleural edge, absence of lung markings, and a deep sulcus sign, while keeping in mind a mediastinal shift is less likely to be present in a stable patient. At this point, you can be sure that the diagnosis is pneumothorax. On the other hand, if you notice findings that are inconsistent with pneumothorax, you should consider an alternative diagnosis. Now that you've diagnosed pneumothorax, the next step is to assess the underlying cause. Ask about a history of trauma to the chest wall and any recent medical procedures where inadvertent trauma may have occurred. If neither of these is present, then the pneumothorax is said to be spontaneous. If spontaneous pneumothorax occurs in the absence of trauma or known lung condition, the pneumothorax is said to be primary. Risk factors for primary spontaneous pneumothorax include young age, tall height, thin body habitus, and being a biologically male individual. Now, the first step in management of a patient with primary spontaneous pneumothorax is to assess the size of the pneumothorax. If it's small, meaning the chest x-ray reveals less than 2 centimeters between the lung edge and chest wall, next you should assess for symptom severity. As long as no symptoms are present, it may often resorb spontaneously, so you can observe your patient. However, if symptoms are present, then you'll need to perform simple needle aspiration or placement of a chest tube. On the other hand, if the pneumothorax is large, in other words, there's 2 centimeters or more in depth, then you will place a chest tube and attach it to continuous suction. Next, order a follow-up chest x-ray to evaluate the lung expansion. If there's full lung expansion, stop the suction and observe your patient for an additional 24 hours. But if the X-ray reveals no lung expansion, make sure to consult the surgical team. Now that we're done with primary spontaneous pneumothorax, let's go all the way back up to the assessment of the underlying cause. Next up are individuals that have no history of trauma but have an underlying lung condition, such as COPD or pulmonary fibrosis. In this case, the pneumothorax is classified as a secondary spontaneous pneumothorax. Here, you will place a chest tube regardless of symptoms or the size of the pneumothorax and attach the tube to continuous suction, again followed by a repeat chest X-ray to evaluate lung expansion. Just like mentioned previously, if there's full lung expansion, stop the suction and observe your patient for an additional 24 hours, but if the X-ray reveals no lung expansion, then you consult the surgical team. Finally, let's go back to the assessment of the underlying cause. And we'll take a look at patients that present with a history of trauma, such as blunt or penetrating trauma, or a history of medical intervention, such as central line placement, lung biopsy, and mechanical ventilation. In this case, you should think of non-spontaneous pneumothorax, so your next step is to assess the chest wall for penetrating injury. If there's no chest wall defect, non-spontaneous pneumothorax is classified as a closed pneumothorax. So, your next step is to assess the pneumothorax size and treat it just like you would treat the primary spontaneous pneumothorax. On the other hand, if there is a chest wall defect, then your diagnosis is open pneumothorax. So, make sure to consult the surgery team, because the chest wall may need surgical repair to allow for proper lung reinflation. Now, here's another high-yield fact. If pneumothorax occurs as a result of a medical intervention, it's called iatrogenic pneumothorax. The most common cause is an inadvertent puncture of the pleura during insertion of a central venous catheter. However, it's also known to occur during needle-based transthoracic procedures like liver biopsy and thoracentesis. They can even occur from mechanical ventilation, usually due to high expiratory pressure settings causing barotrauma. All right. As a quick recap, if you suspect pneumothorax, perform an ABCDE assessment to determine if your patient is unstable or stable. Unstable individuals typically present with tension pneumothorax and usually require immediate decompression with needle thoracostomy prior to placement of a chest tube. On the other hand, in stable individuals, use a chest X-ray to make the diagnosis. Next, review the patient's history to determine the underlying cause and type of pneumothorax. The initial step in the management of primary spontaneous pneumothorax is determine the pneumothorax size. If it's small, observe the patient as long as no symptoms are present. However, if symptoms are present, treat the pneumothorax either with simple needle aspiration or the placement of a chest tube. On the other hand, if the pneumothorax is large, place a chest tube with continuous suction. Next, order a follow-up chest X-ray to evaluate lung expansion. If the X-ray reveals full lung expansion, stop suction and observe the patient for 24 hours. But if there's no lung expansion, consult the surgical team. On the other hand, in secondary spontaneous pneumothorax, place a chest tube regardless of the size of the pneumothorax, attach the tube to continuous suction, and again order a follow-up chest X-ray to evaluate lung expansion. Finally, in non-spontaneous pneumothorax, assess the chest wall for penetrating injury. If there's no chest wall defect, the diagnosis is closed pneumothorax. So your next step is to determine the pneumothorax size and treat it just like you would treat the primary spontaneous pneumothorax. On the flip side, if you notice any chest wall defects, the diagnosis is open pneumothorax. So immediately consult the surgical team.
Gastritis, or inflammation of the gastric mucosa, is typically associated with excessive acid production, which can eventually lead to erosions and ulcerations of the stomach lining, destruction of the glandular layer of the stomach, and fibrosis. Based on the duration of symptoms, gastritis can be classified as acute, persistent, and chronic. Acute and persistent gastritis last less than 30 days and include stress, chemical, and infectious gastritis. On the other hand, chronic gastritis persists for more than 30 days and includes autoimmune, H. pylori, and reactive gastritis. Now, if a patient presents with chief concerns suggesting gastritis, first obtain a focused history and physical exam, as well as labs, including CBC and fecal occult blood test. These patients will report upper abdominal pain, indigestion, and, in some cases, symptoms like nausea, vomiting, and bloating. The physical exam may reveal epigastric tenderness and halitosis, as well as signs of pallor and tachycardia. Moreover, pallor and tachycardia are signs of anemia, which occurs when inflammation of gastric mucosa results in mucosal erosions, ulcers, and subsequent bleeding. So keep in mind that in some individuals, labs might reveal anemia or a positive fecal occult blood test. If your patient presents with these findings, suspect gastritis and assess the duration of symptoms. Symptoms that last 30 days or less are suggestive of acute or persistent gastritis. Moreover, symptoms of acute gastritis last 14 days or less, while symptoms of persistent gastritis last from 15 to 30 days. Both types are associated with the same conditions, so your next step is to assess the underlying cause. First, review the patient's history and physical exam findings, and be sure to order esophagogastroduodenoscopy, or EGD for short, to visualize gastric mucosa and, if needed, take biopsy samples. Additionally, if you suspect infectious gastritis, don't forget to order relevant microbiology testing for bacteria, viruses, fungi, and parasites associated with gastritis. First, let's discuss stress gastritis. In this case, the patient will report a stressful physiological event, such as trauma, shock, sepsis, or surgery, while the EGD will reveal superficial erythematous mucosal erosions. With these findings, diagnose stress gastritis and proceed with treatment, which includes medications for acid suppression, such as proton pump inhibitors or H+2 blockers. Keep in mind that you should also use these medications as prophylaxis in critically ill patients to prevent stress gastritis and potentially life-threatening complications like gastric hemorrhage, perforation, and sepsis. Next up is chemical gastritis. These individuals will report exposure to certain medications, including NSAIDs or corticosteroids, or they might report excessive alcohol consumption. Next, EGD will show subepithelial hemorrhages, erosions, and ulcers of gastric mucosa, while the biopsy will reveal foveolar hyperplasia with mucin depletion and serrated gastric pits. With these findings, diagnose chemical gastritis. Treatment primarily relies on removing the offending irritant, but you can also consider acid suppression with proton pump inhibitors or H+2 blockers. Let's move on to infectious gastritis. In this case, the patient might report symptoms of infection like fever, malaise, and fullness, and the microbiology testing might identify a specific pathogen. Next, the EGD will show erythema, nodular mucosa, or ulceration, while the biopsy will reveal apoptotic cells in the mucosa and, in some cases, gland abscesses. In this case, diagnose infectious gastritis and proceed with treatment, which includes treating the underlying pathogen with or without proton pump inhibitors or H+2 blockers for acid suppression. Now, let's go back and look at individuals reporting that their symptoms have lasted for over 30 days. These findings are suggestive of chronic gastritis, so your next step is to assess the underlying cause. First, let's take a look at autoimmune gastritis. In this case, your patient might report neurological symptoms including tingling, lower extremity weakness, and cognitive changes. Also, there might be a history of autoimmune conditions like Hashimoto thyroiditis and Addison disease. At this point, suspect autoimmune gastritis and order additional labs, including antiparietal cell and anti-intrinsic factor antibodies, as well as gastrin, pepsinogen, iron, and vitamin B12 levels. Finally, be sure to visualize the gastric mucosa using EGD and don't forget to take biopsy samples. In autoimmune gastritis, antiparietal cell and anti-intrinsic factor antibodies might be positive. Moreover, antiparietal cell antibodies stimulate the immune system to destroy acid-producing parietal cells of gastric mucosa, eventually decreasing the production of hydrochloric acid and causing hypochlorhydria. As a result, the body will try to stimulate hydrochloric acid production by secreting more gastrin, so the labs will reveal elevated gastrin levels. Additionally, gastric damage will affect chief cells, which normally secrete pepsinogen. In other words, your patient will have low pepsinogen levels. Next, hypochlorhydria can affect iron absorption, so your patient might present with low iron levels and iron deficiency. Finally, if anti-intrinsic factor antibodies are positive, there will not be enough intrinsic factor, which will result in impaired vitamin B12 absorption and pernicious anemia. Now, here's a high-yield fact to keep in mind. Pernicious anemia is a late manifestation of autoimmune gastritis, characterized by neurological findings because vitamin B12 is crucial for normal functioning of the nervous system. These patients will often present with clinical features like decreased sensation, diminished reflexes, ataxia, and a positive Romberg test. Next, the EGD will show mucosal erythema, nodularity, and atrophic changes of gastric mucosa, while the biopsy will reveal diffuse or multifocal lymphoplasmacytic infiltrates, glandular atrophy, and loss of parietal cells. With these findings, diagnose autoimmune gastritis and initiate acid suppression with proton pump inhibitors and H2 blockers. Also, encourage dietary modification by avoiding triggers like alcohol, coffee, and tobacco, and eating small, frequent meals low in fat and acid. Finally, recommend lifestyle modifications, including stress reduction, smoking cessation, and weight management. Next up is H. pylori gastritis, which might be associated with symptoms like loss of appetite, frequent belching, and unintentional weight loss. With this clinical picture, suspect H. pylori gastritis, so consider non-invasive H. pylori. Finally, recommend lifestyle and H2 blockers. Also, encourage dietary modification by avoiding triggers like alcohol, coffee, and tobacco, and eating small, frequent meals low in fat and acid. Finally, recommend lifestyle modifications, including stress reduction, smoking cessation, and weight management. Next up is H. pylori gastritis, which might be associated with symptoms like loss of appetite, frequent belching, and unintentional weight loss. With this clinical picture, suspect H. pylori gastritis, so consider non-invasive H. pylori testing like urea breath test, H. pylori stool antigen test, or H. pylori serology. However, you should also obtain the EGD with biopsy, which includes the invasive H. pylori rapid urease test, culture, and PCR. In some cases, non-invasive H. pylori testing might be positive, but sometimes the results might come back negative as well. Regardless of non-invasive testing results, if the EGD shows hyperemia, enlargement of mucosal folds, mucosal nodularity, and fundic gland polyps, and biopsy is positive for H. pylori, diagnose H. pylori gastritis. In this case, prescribe triple therapy for 14 days, which includes a proton pump inhibitor, clarithromycin, and amoxicillin or metronidazole. Here's a high-yield fact. H. pylori is a gram-negative bacterium that affects up to 50% of the population worldwide. It's the most common cause of chronic gastritis, peptic ulcer disease, gastric lymphoma, and gastric carcinoma. Finally, let's look at reactive gastritis, which is often associated with long-term NSAID use, alcohol consumption, or bile reflux. With this clinical picture, suspect reactive gastritis and proceed with EGD with biopsy. The endoscopy might be normal or show mucosal erythema, edema, or erosions. However, if the biopsy reveals foveolar hyperplasia and elongation and tortuosity of the gastric folds with a corkscrew appearance, diagnose reactive gastritis. Treatment includes lifestyle modification by removing irritants such as alcohol and NSAIDs. Your patient might need medical therapy, including proton pump inhibitors and H2 blockers for acid suppression, as well as sucralfate and ursodeoxycholic acid to relieve symptoms like abdominal pain and nausea. Alright, as a quick recap, gastritis refers to inflammation of the gastric mucosa, which can be categorized as acute, persistent, or chronic gastritis. Acute and persistent gastritis lasts for less than 30 days and is caused by stress gastritis, chemical gastritis, and infectious gastritis. Treatment includes acid suppression with proton pump inhibitors and H2 blockers, removing the offending chemical, and treating the underlying infection. On the other hand, chronic gastritis lasts for more than 30 days and includes autoimmune gastritis, H. pylori gastritis, and reactive gastritis. Treatment includes a combination of lifestyle modification, dietary modification, and medical therapy, including proton pump inhibitors, H2 blockers, and antibiotics, depending on the underlying cause.
Malaria is a systemic febrile illness caused by the protozoan parasite Plasmodium. It's typically seen in recent travelers of endemic regions, such as Africa, South Asia, and parts of Central and South America. Once transmitted via an infected female Anopheles mosquito, the parasites invade hepatic cells where they reproduce. Next, the parasites invade red blood cells, eventually causing their rupture and causing symptoms like fever, malaise, and chills. Based on the presence and degree of parasitemia, you can diagnose your patient with uncomplicated malaria or severe malaria. Now, if your patient presents with chief concerns suggesting malaria, you should first perform an ABCDE assessment to determine if your patient is unstable or stable. If the patient is unstable, stabilize the airway, breathing, and circulation. Next, obtain IV access and start IV fluids. Then put your patient on continuous vital sign monitoring, including blood pressure, heart rate, and pulse oximetry. Finally, if needed, provide supplemental oxygen to maintain oxygen saturation greater than 90%. Once you stabilize your patient, proceed with a focused history and physical and order labs, primarily CMP, CBC, and coagulation studies such as a PT and PTT. The history typically reveals fever, seizures, and recent travel to a malaria endemic area. Physical examination will likely reveal an elevated temperature, hypotension, tachypnea, and altered level of consciousness. Some patients may even present with recurrent seizures and coma. Here's a clinical pearl to keep in mind. Cerebral malaria is a diffuse symmetric encephalopathy caused by parasites adhering to the cerebrovascular endothelium and puts the patient at risk of permanent neurologic damage or death. If you suspect cerebral malaria, immediately treat with intravenous artesunate to reduce the patient's risk of permanent neurologic damage or death. Next, lab results are nonspecific and could reveal hypoglycemia, low bicarbonate, elevated BUN and creatinine, low hemoglobin and platelets, and elevated PT and PTT. Now, if your patient is presenting with these findings, suspect severe malaria and obtain a thin and thick Giemsa-stained blood smear. If microscopy reveals no Plasmodium parasites identified, consider an alternative diagnosis. However, if the microscopy reveals Plasmodium parasites, you should diagnose severe malaria and start intravenous artesunate. And here's one high-yield fact to keep in mind. In the early stage of the infection, the blood smears could reveal no parasites at all. So, if you have a high clinical suspicion of malaria, start the treatment immediately. Next, repeat the blood smears every 12 to 24 hours for 3 days to confirm your diagnosis. If blood smears reveal no Plasmodium after 3 days, you can rule out malaria and stop the treatment. Now, let's go back to the ABCDE assessment and take a look at stable individuals. If your patient is stable, first obtain a focused history and physical examination. Your patient will usually report periodic fever, myalgia, and fatigue, as well as recent travel to a malaria endemic area. Additionally, on a physical exam, you might find an enlarged liver or spleen, or even mild jaundice. Here's a high-yield fact. There's many species of Plasmodium, and they may present with various fever patterns. Plasmodium malariae causes quartan fever, where the fever episodes occur every 72 hours or every 4th day and are generally milder than other types. Plasmodium vivax and Plasmodium ovale can cause tertian fever, where the episodes occur every 48 hours or every 3rd day. Plasmodium knowlesi is associated with quotidian fever, where the episodes occur every 24 hours or every 2nd day. Lastly, Plasmodium falciparum often presents with an irregular fever pattern without a distinct periodicity like the other types, and tends to be more severe with potentially life-threatening complications. At this point, you should suspect malaria, so don't forget to obtain a thin and thick Giemsa-stained blood smear for evaluation under microscopy. The thin smear identifies the type of Plasmodium species within red blood cells and is also used to calculate parasite density, expressed as percent parasitemia. On the other hand, the thick smear is a larger sample of blood that contains lysed red blood cells, and while it identifies Plasmodium species, it cannot calculate parasite density. Now, here's a clinical pearl. In malaria endemic areas without access to extensive laboratory testing, you can use malaria rapid diagnostic tests, or RDTs for short. However, keep in mind that this type of testing cannot identify the Plasmodium species or measure parasitemia, so treatment is based on the region's predominant Plasmodium species and drug resistance patterns. Okay, once you obtain thin and thick smears, assess the presence and degree of parasitemia. The results may reveal that the parasite density is 5% or greater. In this case, diagnose severe malaria once again and immediately proceed with intravenous artesunate regardless of the Plasmodium species. On the other hand, if you do detect Plasmodium and the parasite density is less than 5%, diagnose uncomplicated malaria. Next, assess the causative organism based on the blood smear. The blood smear may reveal Plasmodium falciparum. This is the most common species of malaria identified in the United States. In addition, it is the most common cause of severe malaria worldwide. At this point, you can diagnose Plasmodium falciparum malaria and treat your patient with the combination medication artemether and lumefantrine. Next, the blood smear identifies Plasmodium vivax. After you diagnose malaria caused by Plasmodium vivax, treatment is again based on the combination of artemether and lumefantrine. An important thing to keep in mind is that Plasmodium vivax, along with Plasmodium ovale, are the only species that can form hypnozoites, which lie dormant in the liver after symptoms clear and can reactivate months later, leading to recurrent malaria episodes. Therefore, for these species, add primaquine to eradicate the dormant intrahepatic parasites to prevent relapse. Next, the blood smear may show Plasmodium ovale. After diagnosing malaria caused by Plasmodium ovale, proceed with treatment, this time with chloroquine instead of artemether and lumefantrine. Also, remember to add primaquine for those hypnozoites. Here's a high-yield fact that concerns both Plasmodium vivax and ovale. Before prescribing primaquine, be sure to always screen your patient for G6PD deficiency since they'll need a modified regimen and close monitoring. That's because patients with G6PD deficiency are more susceptible to damage from stressors, including medications like primaquine, which can lead to acute hemolysis. Let's move on to our next blood smear. If the blood smear analysis reveals Plasmodium malariae, proceed with treatment with chloroquine. No need to add primaquine here. And now our final blood smear. If you identify Plasmodium knowlesi, diagnose malaria caused by Plasmodium knowlesi, and, once again, treat your patient with chloroquine. Here's a high-yield fact. Your patient's anti-malarial regimen may change if there's known chloroquine resistance in the region, or if they took the same prophylaxis as the anti-malarial indicated for an acute infection. For example, if your patient took chloroquine for malaria prophylaxis but contracted malaria anyway, then your patient should be treated with a different anti-malarial regimen, such as artemether and lumefantrine. One last clinical pearl. During treatment, blood smears should be repeated every 12 to 24 hours to make sure that the parasite density decreases. A blood smear that demonstrates improvement or resolution of parasitemia proves effective treatment. Okay, now let's go all the way back to the thin and thick Giemsa blood smear one last time. If the blood smear reveals no Plasmodium parasites identified, you should consider an alternative diagnosis. Alright, as a quick recap, malaria is a systemic, febrile illness caused by the protozoan parasite Plasmodium, which invades and destroys red blood cells. Unstable patients with Plasmodium species observed on blood smear have severe malaria, and they are treated with IV artesunate regardless of the Plasmodium species. For stable patients, you need to assess the degree of parasitemia. Patients with parasitemia of 5% or greater are also considered to have severe malaria and should be treated with IV artesunate. On the other hand, those with parasitemia lower than 5% have uncomplicated malaria. Depending on the causative Plasmodium species identified, pick the appropriate anti-malarial medication, such as artemether and lumefantrine, chloroquine, and primaquine.
Epilepsy is a neurological condition characterized by recurrent, unprovoked seizures which refer to sudden changes in the brain's electrical activity that can result in various clinical manifestations, including convulsions and loss of consciousness. Now, there are several different types of seizures, including tonic-clonic, myoclonic, atonic, and absence seizures. All seizures can be classified as focal or generalized based on the affected brain area. All right, if a patient presents with a chief concern suggestive of epilepsy, first perform an ABCDE assessment. If the patient is unstable, stabilize their airway, breathing, and circulation. You might need to intubate your patient and start mechanical ventilation. Next, obtain IV access and put your patient on continuous vital signs monitoring, including heart rate, blood pressure, and pulse oximetry, as well as cardiac telemetry. Most commonly, unstable individuals are presenting with convulsive status epilepticus. So once you stabilize the patient, your next step is to obtain a focused history and physical examination. History will reveal a tonic-clonic seizure that started 5 or more minutes ago, or multiple seizures without recovery to baseline mental status between attacks. On the physical exam, you will notice an altered mental status and alternating body stiffening and jerking movements. With these findings, diagnose convulsive status epilepticus. Here's a clinical pearl to keep in mind. Immediate treatment for convulsive status epilepticus includes benzodiazepines such as lorazepam, midazolam, or diazepam, followed by anti-seizure medications like phosphonatoin, phenobarbital, valproic acid, or levetiracetam. Once you initiate the treatment, you can use EEG to monitor clinical response. Also, you can use EEG to assess for non-convulsive status epilepticus, which is a condition associated with abnormal brain activity with no or just a few physical manifestations. Now, let's go back to the ABCDE assessment and focus on stable individuals. In this case, obtain a focused history and physical exam. History usually reveals at least 2 unprovoked seizures more than 24 hours apart, which is enough to confirm the diagnosis of epilepsy. However, to call a seizure unprovoked, you need to rule out secondary causes of seizures, such as alcohol withdrawal, hypoglycemia, or sepsis. Some individuals with epilepsy might report a remote history of head trauma, CNS infection, and stroke, as well as degenerative or congenital CNS conditions like prion disease or tuberous sclerosis. Lastly, there might be a family history of epilepsy. Depending on the underlying cause, the physical exam between seizures may or may not be normal. At this point, you can diagnose epilepsy. Now here's a clinical pearl. In addition to focused history and physical examination, the workup for epilepsy also includes EEG and brain imaging like CT or MRI. This is because one unprovoked seizure, in combination with risk factors such as an abnormal EEG finding that fits a known epilepsy syndrome or cortical dysplasia on brain imaging, is enough to confirm the diagnosis of epilepsy. All right, once you diagnose epilepsy, your next step is to assess the type of seizure. First, let's focus on tonic-clonic seizures, which start with the tonic phase, characterized by muscle stiffness and extension of the limbs. During this phase, the patient might become cyanotic because they're not breathing, and they could also bite their tongue. Additionally, the contraction of abdominal muscles and diaphragm can force air through closed vocal cords and cause a specific crying sound called ictal cry. The tonic phase is followed by the clonic phase, which is characterized by a period of jerking movements throughout the body. During this phase, the patient might experience urinary or stool incontinence. Once the seizure resolves, there is a period of confusion, also known as post-ictal confusion. With these findings, you can diagnose tonic-clonic seizures. On the flip side, myoclonic seizures are characterized by irregular, brief, fast muscle or limb jerking movements. Myoclonic movements can sometimes be difficult to differentiate from clonic movements, but myoclonic jerks are more irregular and faster, sometimes described as lightning-fast movements. Additionally, this type of seizure can occur as a result of hypoxic brain injury after cardiac arrest or anoxic brain injury. With these findings, diagnose myoclonic seizures. Time for a high-yield fact. Juvenile myoclonic epilepsy is one of the most common types of epilepsy in adolescents. Individuals typically have normal development, and their seizures tend to occur in the morning or when they are not getting enough sleep. For example, when studying for final exams. This type of seizure is photosensitive, meaning your patient might experience attacks when looking at flashing or flickering lights. Finally, the EEG will show 3 to 5.5 Hz generalized polyspike and wave discharges. Next up are atonic seizures, which are associated with very brief episodes of loss of consciousness. The patient will suddenly collapse to the ground, or the head will droop. With this presentation, Diagnose atonic seizures. Finally, let's look at absence seizures, which are non-motor seizures. In this case, history will reveal that the patient has brief episodes of unresponsiveness, characterized by staring off into space or having a blank expression. During the episode, the patient might present with repetitive small, localized movements such as eye blinking or head nodding. Remember, these individuals will have no period of confusion afterward, meaning they will immediately go back to what they were doing before the seizure. One important thing to keep in mind is that in most patients, you can provoke this type of seizure with hyperventilation. These findings are highly suggestive of typical absence seizures. Here's another clinical pearl. Childhood absence epilepsy occurs in children with normal development and has a high rate of remission by adolescents. These seizures are often mistaken for behavioral and attention issues, so you can obtain an EEG, which reveals 3 Hz generalized spike and wave complexes. The first-line treatment for childhood absence seizures is ethosuximide. Once you determine the specific type of seizure, the next step is to assess the onset of seizure activity. You can do this by clinically witnessing a seizure or by ordering EEG. Clinically, you might see generalized body jerking movements or an absence seizure without any focal movements beforehand. Similarly, if the EEG reveals abnormal bilateral and simultaneous electrical activity, diagnose generalized seizures. All patients with generalized seizures will have a loss of consciousness. On the flip side, if you notice focal motor movements or the EEG reveals abnormal focal electrical activity of the brain, diagnose focal seizures. Now here's a clinical pearl. In all types of focal seizures, you should obtain brain imaging to assess for possible structural lesions that could cause the seizure. However, remember that the history and seizure descriptions can also suggest what part of the brain is affected. For example, the seizure characterized by a progressive spread of jerking throughout a limb is known as a Jacksonian march due to epileptic activity spreading through the motor cortex in the frontal lobe. The sensation of déjà vu, fear or anxiety, an abnormal smell, or automatisms preceding a seizure suggest a temporal lobe seizure. This kind of seizure might be a result of mesial temporal lobe sclerosis or simply hippocampal sclerosis, in which there is scarring and neural loss in the hippocampus affecting neuronal circuits. Finally, visual hallucinations or seeing flashing lights point to an occipital lobe seizure. Sometimes seizures can be focal in onset and quickly spread and affect the whole brain, causing generalized seizures. These seizures are called focal to bilateral tonic-clonic seizures. In this case, it's hard to clinically determine the type, so carefully assess the EEG findings, which will reveal abnormal electrical activity that starts focally, then becomes diffuse. Some examples of focal and generalized seizure syndromes include Dravet and Lennox-Gastaut syndromes. Dravet syndrome presents in early infancy and usually begins as clonic seizures affecting half of the body and progresses to involve other seizure types. On the flip side, Lennox-Gastaut syndrome usually presents in early childhood and consists of multiple seizure types, particularly tonic seizures. Both syndromes are medically refractory and associated with intellectual disability. Once you diagnose focal seizures, the next step is to assess for impaired awareness during the seizures. This could range from mild confusion to loss of consciousness. If there is no impaired awareness, diagnose focal aware seizures. However, if you notice impaired awareness, diagnose focal impaired awareness seizures. Here's one last high-yield fact to keep in mind. The management primarily includes anti-seizure medications. First, there's valproic acid, which is a broad-spectrum medication used to treat both generalized and focal seizures. However, it can cause pancreatitis and thrombocytopenia. Another important side effect involves neural tube defects, so you should avoid it in biological female individuals of childbearing age. Levetiracetam is another medication used for both generalized and focal seizures, but it can cause or worsen mood disorders such as depression and cause irritability and aggression. Another option for generalized and focal seizures is topiramate, which is associated with adverse effects like birth defects such as cleft lip or cleft palate, kidney stones, weight loss, and even glaucoma. Medications more commonly used for focal than generalized seizures include carbamazepine, which can cause hyponatremia and serious skin reactions like Stevens-Johnson syndrome or toxic epidermal necrolysis, and phenytoin, which can cause hepatotoxicity and osteoporosis. If seizures are medically refractory, you can consider surgical resection of a structural lesion such as sclerosis, or vagal nerve stimulator placement, which works by sending electrical impulses to the brain via the vagus nerve and altering electrical activity and levels of neurotransmitters in the brain. All right, as a quick recap, if your patient presents with a chief concern suggesting epilepsy, first perform the ABCDE assessment to rule out the possibility of convulsive status epilepticus. Next, obtain a focused history and physical exam. If history reveals at least 2 unprovoked seizures more than 24 hours apart, you can diagnose epilepsy. However, to call a seizure unprovoked, you need to rule out secondary causes of seizures, such as alcohol withdrawal, hypoglycemia, and sepsis. Once you diagnose epilepsy, your next step is to determine the type. Some important types include tonic-clonic, myoclonic, atonic, and absence seizures. Finally, don't forget to assess the onset of seizure activity, which is going to help guide the management.
Mood refers to a long-lasting emotional state that influences how a person views the world and behaves. So, mood disorders are characterized by persistent and excessive experiences of emotions such as happiness, sadness, and irritation to a degree that affects an individual's overall functioning. Now, if a patient presents with chief concerns suggesting a mood disorder, first perform a safety assessment. Assess for features of psychosis, like agitation, paranoia, aggression, signs of auditory or visual hallucinations, and other forms of severely disorganized thoughts, speech, or behavior. Additionally, look for signs of mania, such as rapid speech, a decreased need for sleep, and an increase in goal-directed activity. Finally, ask specifically about homicidal and suicidal ideation. Patients experiencing psychosis, mania, and active homicidality or suicidality are considered high risk to themselves and others, so proceed with acute management, which often requires psychiatric hospitalization, pharmacologic stabilization, and a one-to-one sitter, if appropriate. On the other hand, if the patient is not experiencing these features, they are considered low risk to themselves and others, so your next step is to obtain a focused history and physical exam. History will typically reveal a persistently euphoric, irritable, or depressed mood that is significantly different from their baseline. Next, on the exam, you will notice psychomotor changes such as slowed or agitated movements, changes in the rate of speech, which can be increased or decreased, and extremes of affect, ranging from flat to exaggerated facial expressions. Finally, you might notice changes in appearance, such as being unusually unkempt. With these findings, you should consider mood disorder. Now, here's a clinical pearl to keep in mind. When assessing patients with mood disorders, be sure to rule out other medical conditions as potential causes of mood changes. For example, hypothyroidism can contribute to depression, while encephalitis can result in manic and psychotic symptoms. Additionally, intoxication or withdrawal from substances such as alcohol, cocaine, amphetamines, opioids, and benzodiazepines can also lead to mood disturbances. Next, assess for a current or past manic episode using the DSM-5 criteria. Manic episodes are characterized by a persistently euphoric or irritable mood with increased energy. In addition, there must be at least 3 of the following symptoms, which can be remembered using the mnemonic DIG FAST. DIG refers to distractibility, irresponsibility, including high-risk behaviors such as reckless driving, expensive shopping sprees, and sexual indiscretion, and grandiosity and unrealistic self-confidence. Next, F stands for flight of ideas, while A refers to psychomotor agitation, but also increased goal-oriented activities involving excessive planning, multitasking, increased sociability, and sexual drive. Finally, S stands for sleep deficiency but still feeling rested and energetic, and T for excessive talkativeness that is rapid and hard to interrupt. Sometimes the patient might present with psychotic features such as hallucinations, delusions, or severely disorganized thought, speech, and behavior. Next, the manic episode must be at least 1 week or any duration of time if symptoms are severe enough to require hospitalization. Finally, symptoms must cause clinically significant impairment. If the patient meets the criteria for a current or past manic episode, diagnose bipolar I disorder. Here's another clinical pearl. To diagnose bipolar I disorder, the patient must meet the criteria for a manic episode. However, manic episodes in bipolar I disorder can often be followed or preceded by hypomanic and major depressive episodes. Hypomania is a less severe, less impairing form of mania and typically lasts for a few days, although some episodes can last weeks or even months. These episodes are often interspersed with periods of stable mood, but a person may switch directly from one pole, mania, to the other pole, depression. On the other hand, if there is no history of a manic episode, assess for a current or past hypomanic episode using the DSM-5 criteria. Like mania, hypomania is characterized by a persistently euphoric or irritable mood with increased energy and the presence of 3 or more DIG-FAST symptoms. But in contrast to manic episodes, hypomanic episodes are not associated with psychotic features. Next, the hypomanic episode must last at least 4 days and should not require hospitalization. Finally, symptoms must cause clinically significant changes in function, but they cannot be severe enough to cause impairment. If the patient meets all the criteria for a current or past hypomanic episode, the likely diagnosis is bipolar II disorder. Here's a high-yield fact. In order to make the diagnosis of bipolar II disorder, the patient must experience at least 1 hypomanic episode, 1 major depressive episode, and no manic episodes. Similar to bipolar I disorder, mood episodes in bipolar II disorder also recur, with major depressive episodes being more frequent, longer lasting, and more severe compared to bipolar I disorder. On the flip side, if there is no history of a hypomanic episode, assess for a current or past major depressive episode using the DSM-5 criteria. To diagnose a major depressive episode, the patient must have at least 5 of the following 9 symptoms. These include consistently depressed mood, too much or too little sleep, lack of interest and pleasure in previously enjoyed activities, social withdrawal and decreased sexual drive, guilt and feelings of worthlessness, decreased energy, poor concentration, changes in appetite, psychomotor slowing or agitation, and finally, suicidality with recurrent thoughts of death, including passive thinking, active planning, as well as suicide attempts. Keep in mind that at least one of these symptoms must be a consistently depressed mood or lack of interest and pleasure in previously enjoyed activities. In addition to consistently depressed mood, you can easily remember the last 8 symptoms using the mnemonic SIG-E caps. Additionally, the patient might present with psychotic features like hallucinations or delusions. Finally, symptoms must last at least 2 weeks and cause clinically significant distress or impairment. If the patient meets the criteria for a major depressive episode, think of major depressive disorder. Keep in mind that in order to diagnose major depressive disorder, your patient must experience at least one major depressive episode and have no history of manic or hypomanic episodes. Here's another clinical pearl. Individuals with bipolar mood disorders often present during a major depressive episode, making it crucial to assess all depressed patients for any history of mania or hypomania. This is important because starting antidepressant monotherapy might trigger or unmask manic or hypomanic symptoms. Additionally, after diagnosing major depressive disorder and initiating antidepressant therapy, monitor the patient for new manic or hypomanic symptoms and, if needed, update their diagnosis to bipolar I or bipolar II disorder. Now, let's go back and look at individuals with no current or past major depressive episodes. In this case, your next step is to assess for key features of the patient mood disorder. If a patient reports persistent sadness, consider persistent depressive disorder, or PDD. Next, use the DSM-5 criteria to assess for PDD, which is characterized by a persistently depressed mood lasting at least 2 years in adults and at least 1 year in children and adolescents. During this period, the patient must experience 2 or more of the following 6 symptoms. These include poor concentration, feeling hopeless, changes in eating habits like overeating or poor appetite, low self-esteem, sleep disturbances such as insomnia or hypersomnia, and low energy. Moreover, use the mnemonic CHEESE to remember these 6 symptoms. Next, during the 2 years in adults and 1 year in children and adolescents, the patient has never been without symptoms for more than 2 months. Finally, symptoms that the patient is experiencing must cause clinically significant distress or impairment. If the patient meets the criteria, diagnose persistent depressive disorder. Next, if a patient presents with frequent mood swings, consider cyclothymic disorder, so proceed with the DSM-5 cyclothymic disorder criteria. Cyclothymic disorder is characterized by a persistent pattern of unpredictable mood changes lasting over 2 years in adults or over 1 year in children and adolescents. During this period, the patient must experience periods of hypomanic symptoms alternating with periods of depressive symptoms. But keep in mind that your patient should not meet the criteria for hypomanic and major depressive episodes. Next, during these 2 years in adults and 1 year in children and adolescents, there should be no symptom-free intervals lasting more than 2 months. Finally, these mood changes must cause clinically significant distress or impairment. If all criteria are met, diagnose cyclothymic disorder. On the other hand, if mood symptoms are closely associated with the patient's menstrual cycle, consider premenstrual dysphoric disorder, or PMDD. So, assess the DSM-5 PMDD criteria. PMDD is a severe form of premenstrual syndrome characterized by significant mood changes, which start during the week before menstruation and begin to resolve a few days after the onset of menstruation. These include severe mood swings, intense irritability or anger, depression, anxiety, or feelings of being overwhelmed, as well as physical symptoms like bloating, breast swelling or tenderness, and joint or muscle pain. These symptoms should be present in most menstrual cycles. Also, the symptoms should cause clinically significant distress or impairment in everyday activities. If all criteria are met, diagnose premenstrual dysphoric disorder. Finally, if your patient developed mood symptoms after a major life situation, consider adjustment disorder. Again, assess for the DSM-5 criteria for adjustment disorder, which is characterized by mood symptoms and distress disproportionate to a known stressor like job loss, divorce, or natural disaster. Symptoms appear within 3 months of the event and resolve within 6 months after it ends. Mood symptoms may manifest as depression or anxiety and lead to behavioral issues like aggression, refusal to follow rules, or risky behaviors such as substance use. Symptoms must cause clinically significant distress or impairment. If your patient meets the criteria, diagnose adjustment disorder. Here's one last clinical pearl to keep in mind. Disruptive mood dysregulation disorder, or DMDD, occurs only in children. It's characterized by a severe and persistently irritable or angry mood, along with frequent temper outbursts that are developmentally inappropriate and have persisted for at least a year. Children with DMDD are at an increased risk of developing depressive or anxiety disorders in adulthood, but they are unlikely to develop bipolar disorder. Alright, as a quick recap. When assessing a patient with mood disorder, first perform the safety assessment, then obtain a focused history and physical exam. Use the DSM-5 criteria to assess for manic, hypomanic, and major depressive episodes. A current or past manic episode suggests bipolar 1 disorder. A current or past hypomanic episode combined with a major depressive episode indicate bipolar 2 disorder, while a major depressive episode without mania or hypomania is suggestive of major depressive disorder. Finally, assess for key features where persistent sadness may indicate persistent depressive disorder, frequent mood swings may suggest cyclothymic disorder, and mood symptoms linked to menstrual cycles likely represent premenstrual dysphoric disorder. If mood symptoms develop after a major life stressor, think of adjustment disorder.
Headache and facial pain are common presentations that can occur due to various benign and concerning conditions. Primary headaches, which are not caused by other conditions, include tension-type headache, cluster headache, and migraine. On the flip side, secondary headaches are a presentation of an underlying condition, such as giant cell arteritis, infectious meningitis, and subarachnoid hemorrhage. Now, if your patient presents with a headache or facial pain, first perform an ABCDE assessment to determine if they are stable or unstable. If unstable, stabilize their airway, breathing, and circulation. You might need to intubate your patient and provide mechanical ventilation. Next, obtain IV access and put your patient on continuous vital sign monitoring and cardiac telemetry. Finally, you might need to manage increased intracranial pressure. Okay, let's go back and talk about stable patients. In this case, obtain a focused history and physical examination, including a fundoscopic exam. First, let's focus on facial pain, more specifically trigeminal neuralgia. These patients typically report recurrent, unilateral facial pain lasting a few seconds to minutes, often described as sharp pain or electric shock. The pain is usually precipitated by minor stimuli such as shaving, toothbrushing, or chewing. The physical exam is usually normal, but sometimes you might find a sensory loss in the face. Finally, if the fundoscopic exam is normal, diagnose trigeminal neuralgia. Alright, now let's focus on individuals presenting with headaches. Next to the headache, history might reveal visual disturbances, fever, nausea, and vomiting. On the exam, you might notice altered mental status or focal neurologic deficits. Finally, the fundoscopic exam could be normal, or it might show optic disc edema, also known as papilledema, which occurs due to increased intracranial pressure. These findings are suggestive of headaches, so your next step is to assess for red flags using the Snoop 10 criteria. These include systemic symptoms, such as fever, neoplasm, neurologic deficits, sudden onset of headache, and older age, greater than 50. The 10 Ps include pattern change in headache, positional headache, meaning that the quality changes depending on the patient's position, such as standing versus laying down, headaches precipitated by activities that increase intracranial pressure, such as sneezing or coughing, papilledema, progressive headache, pregnancy, painful eye, post-traumatic headache, pathology of the immune system, such as HIV, and painkiller overuse. If red flags are absent, consider primary headache and ask about the laterality of headaches. If the headache is bilateral, consider a tension-type headache, so assess the criteria for tension-type headaches. These headaches can last minutes to days and must meet at least 2 of the following 4 characteristics. First, these headaches are associated with a pressing or tightening sensation. Sometimes, your patient will describe this feeling as having a non-pulsating band of pressure around the head. Next, headaches should be bilateral and mild to moderate in intensity, but they should not worsen by routine physical activity, such as walking. Finally, tension-type headaches are usually not associated with nausea, vomiting, photophobia, or phonophobia. However, some patients might present with either photophobia or phonophobia, not both. If your patient meets these criteria, diagnose tension-type headaches. On the flip side, if the headache is unilateral, consider cluster headaches or migraine. Next, assess whether the headache is associated with either restlessness or ipsilateral autonomic features, such as lacrimation and rhinorrhea. If either of those characteristics is present, suspect cluster headaches and assess the criteria. The patient should describe headaches as severe, unilateral pain in the orbital, supraorbital, or temporal region that typically lasts 15 minutes to 3 hours. These headaches are frequent and occur at least every other day, sometimes multiple times a day. As mentioned, they should be associated with restlessness or agitation and/or ipsilateral autonomic features, including conjunctival injection or lacrimation, nasal congestion or rhinorrhea, eyelid edema, forehead and facial sweating, and meiosis or ptosis. If the patient meets these criteria, diagnose cluster headache. Now, let's go back and look at individuals reporting no restlessness or ipsilateral autonomic features. In this case, suspect migraine headaches and assess whether your patient meets the criteria for migraines. Migraines last hours to days and have at least 2 of the following 4 features: unilateral in location, pulsating quality, moderate to severe pain intensity, and they are worsened by or cause avoidance of routine physical activity such as walking. Finally, in contrast to tension-type headaches, migraines are associated with nausea, vomiting, photophobia, and phonophobia. If your patient meets the criteria, diagnose migraines. Alright, let's go back and take a look at individuals who are presenting with red flags. In this case, consider a secondary headache and obtain a head CT. If the CT is normal, consider conditions like giant cell arteritis, meningitis, medication overuse headache, and idiopathic intracranial hypertension. First, let's discuss giant cell arteritis, also known as temporal arteritis, which is typically seen in individuals 50 years of age and older. In addition to headache, history reveals pain over the scalp or temple, vision loss, and pain with chewing, which is known as jaw claudication. Additionally, there might be a history of polymyalgia rheumatica. The exam might show tenderness to palpation along the course of the temporal artery in front of the ear and on the side of the head. Finally, if the fundoscopic exam shows optic disc swelling and pallor, consider giant cell arteritis. Next, obtain labs, including erythrocyte sedimentation rate, ESR, and CRP, and a temporal artery biopsy. If the erythrocyte sedimentation rate and CRP are elevated, and the biopsy reveals transmural inflammation, multinucleated giant cells, and mononuclear infiltrates, diagnose giant cell arteritis. Let's move on to infectious meningitis, which is associated with headache, fever, and neck stiffness. History might also reveal nonspecific symptoms like nausea and vomiting, but also sensitivity to light, confusion, and seizures. The physical exam reveals signs of meningeal irritation, including nuchal rigidity and positive Brudzinski and Koenig signs. Next, you might find altered mental status or focal neurologic deficits. Depending on whether there is increased intracranial pressure or not, the fundoscopic exam might show papilledema. With these findings, consider infectious meningitis. Obtain a CSF sample for basic labs, culture, and PCR. If the CSF analysis reveals an elevated white blood cell count, elevated protein, and a positive culture or PCR, diagnose infectious meningitis. Now, let's look at medication overuse headaches. In this case, your patient will report worsening of pre-existing headaches and chronic use of medications used to treat headaches, including NSAIDs, acetaminophen, triptans, and opioids. Patients usually report that the medications are becoming less effective, meaning they have to take more medicine to get any relief. If the physical exam and fundoscopy are normal, consider a medication overuse headache and assess the criteria for diagnosis. First, a person with a pre-existing headache disorder is experiencing headaches at least 15 days per month. Second, there should be at least 3 months of regular overuse of one or more medications used to treat headaches. If your patient meets these 2 criteria, diagnose medication overuse headache, which usually resolves after reducing or stopping the overused medications. Finally, let's focus on idiopathic intracranial hypertension, which is typically seen in obese biological females of reproductive age. The patient reports headaches that are more severe with Valsalva maneuvers, such as sneezing or coughing. Additionally, they report episodes of visual disturbances, such as transient vision loss or double vision. In some cases, a patient might mention hearing pulsating sounds, known as pulsatile tinnitus, which occurs due to turbulent blood flow in narrowed transverse and sigmoid venous sinuses. On the exam, you might find visual field loss, decreased visual acuity, and abducens nerve palsy. For example, in a case of unilateral abducens nerve palsy, when the patient tries to look straight ahead, the affected eye will drift medially toward the nose, causing double vision. On lateral gaze towards the unaffected side, the patient will adduct the affected eye normally toward the nose, which improves their double vision. Finally, if the fundoscopy reveals papilledema, consider idiopathic intracranial hypertension, so be sure to obtain a brain MRI and venography. Also, you should perform a lumbar puncture to check the opening pressure and obtain a CSF sample for analysis. If the brain MRI and venography are normal, the opening pressure is 25 centimeters of water or greater, and the CSF analysis is normal, diagnose idiopathic intracranial hypertension. Now, switching gears and moving on to individuals with secondary headaches and abnormal head CT findings. In this case, consider vascular etiologies, such as subarachnoid hemorrhage and venous sinus thrombosis. Patients with subarachnoid hemorrhage typically report the worst headache of their life, which is often called a thunderclap headache because the pain is maximum at onset. In some cases, a few days or a few weeks before the patient's presentation, they had a milder sudden headache called a warning or sentinel headache. This type of headache occurs due to aneurysmal wall stretching or minor aneurysmal leak and is often a sign of impending aneurysmal rupture. Also, they might report cardiovascular risk factors such as hypertension and tobacco use, as well as a family history of cerebral aneurysms. The physical exam reveals nuchal rigidity, possibly in combination with an altered mental status and focal neurologic deficits. Additionally, the fundoscopic exam reveals papilledema with or without a boat-shaped hemorrhage called a subhyaloid hemorrhage. Finally, if the head CT reveals a hemorrhage in the subarachnoid space, diagnose subarachnoid hemorrhage. Next, let's take a look at venous sinus thrombosis. These patients report progressive worsening of their headache that might be associated with nausea, vomiting, confusion, and even seizures. Some important risk factors include infections such as COVID-19 and mastoiditis, but also pregnancy and the use of oral contraceptives. Other important risk factors include recent head trauma, neurosurgical procedures, and genetic or acquired thrombophilia. On physical exam, you might find altered mental status and focal neurologic deficits. The head CT will reveal a hyperdensity or filling defect in one of the dural venous sinuses. At this point, consider venous sinus thrombosis, so immediately obtain CT or MR venography. If venography reveals a thrombus in a dural venous sinus, diagnose venous sinus thrombosis. Here's a clinical pearl. Patients with intracranial neoplasms or abscesses might also present with progressive headaches. Alright, as a quick recap, if the patient presents with facial pain, consider trigeminal neuralgia. However, if the patient presents with a headache, assess for red flags using the Snoop 10 criteria. If absent, think of primary headaches like tension-type headache and migraine. On the other hand, if red flags are present, obtain a head CT. If the head CT is normal, consider giant cell arteritis, meningitis, medication overuse headache, and idiopathic intracranial hypertension. However, if the head CT is abnormal, think subarachnoid hemorrhage or venous sinus thrombosis. Hypothermia is defined as a core body temperature of less than 95 degrees Fahrenheit or 35 degrees Celsius. It occurs when your body expends more heat than it creates, typically due to prolonged exposure to cold, like getting stuck in a snowstorm or losing heat in homes during the winter. Based on the core temperature, hypothermia is divided into mild, moderate, and severe hypothermia. Regardless of the severity, hypothermia puts the individual at a very high risk of becoming hemodynamically unstable and is life-threatening, so it must be managed promptly. Now, if you suspect the patient has hypothermia, you should first perform an ABCDE assessment. Acute management should be started immediately to stabilize the patient's airway, breathing, and circulation. Next, obtain IV access and consider starting warmed IV fluids. Next, put your patient on continuous vital sign monitoring, including body temperature, blood pressure, heart rate, and pulse oximetry, as well as cardiac telemetry. Finally, if your patient is in cardiac arrest, manage according to ACLS guidelines. Next, obtain a focused history and physical examination, as well as a 12-lead ECG. Your patient will have a history of prolonged cold exposure. History could also reveal risk factors like a history of alcohol use, older age, or that your patient is experiencing homelessness. They may also have severe manifestations of psychiatric conditions like mania or psychosis. Physical examination will reveal a core temperature lower than 95 degrees Fahrenheit or 35 degrees Celsius, as well as hyperventilation initially, and may progress to hypoventilation as core temperature continues to decrease. In addition, you may notice shivering, but keep in mind that shivering will eventually stop if exposure to cold continues. And your patient may also develop confusion, lethargy, and reduced responsiveness. The ECG may reveal sinus tachycardia initially, or progress to sinus bradycardia or a junctional rhythm. Keep in mind that junctional rhythm can be distinguished from a sinus bradycardia by the absence of P waves. Additionally, you might notice Osborn waves, also known as J waves, which refer to positive deflections at the junction between the QRS complex and ST segment. Osborn waves are most noticeable in precordial leads such as V3, V4, V5, and V6, and their height roughly correlates with the severity of hypothermia. In more severe cases, the ECG may even reveal ventricular arrhythmias or even asystole. Here's a clinical pearl to keep in mind. If your patient's vital signs or level of consciousness do not match the degree of hypothermia, consider an underlying medical condition, such as infection, trauma, or metabolic conditions like hypothyroidism, adrenal insufficiency, and hypoglycemia. For example, your patient might present with decreased responsiveness, hypotension, bradycardia, and mild hypothermia, which refers to a core temperature of 90 to 95 degrees Fahrenheit or 32 to 35 degrees Celsius. In this case, you need to order additional laboratory tests like a CBC and CMP to identify an underlying cause. Okay, so if your patient presents with these signs and symptoms, you can diagnose hypothermia. Now, once you diagnose hypothermia, your next step is to assess the degree of hypothermia by measuring the patient's core temperature. You should measure the patient's core temperature using a low-reading thermometer, because standard thermometers cannot accurately measure a core temperature below 95 degrees Fahrenheit or 35 degrees Celsius. The most accurate location to obtain a core temperature is the lower one-third of the esophagus due to its proximity to the heart. However, this requires the passage of an esophageal probe and may not always be practical, so it's more common to obtain a core temperature from the bladder and rectum. Alright. If the patient's core temperature ranges between 90 and 95 degrees Fahrenheit or 32 and 35 degrees Celsius, you can classify it as mild hypothermia, so begin passive external rewarming. This includes removing the patient out of the cold if possible, removing any wet clothing, and covering the patient with a blanket or dry garments. If the patient doesn't respond to passive external rewarming, consider active external rewarming with warm blankets, heating pads, warm baths, or forced warm air. Okay, let's go back and assess our patient's degree of hypothermia. If your patient's core temperature is between 82 degrees Fahrenheit and 90 degrees Fahrenheit, or in other words, between 28 degrees Celsius and 32 degrees Celsius, these findings are highly suggestive of moderate hypothermia, so immediately begin passive and active external rewarming. If the patient doesn't respond to external rewarming measures, consider active internal rewarming with warm IV fluids, or even peritoneal or pleural lavage with warm fluids. Now let's go back one last time. If your patient's core temperature is below 82 degrees Fahrenheit or 28 degrees Celsius, you're dealing with severe hypothermia. Your next step is to quickly initiate comprehensive rewarming, which includes passive and active external rewarming, as well as active internal rewarming. In addition, if your patient is hemodynamically unstable or in cardiac arrest, you should consider extracorporeal rewarming, which may include hemodialysis, cardiopulmonary bypass, and extracorporeal membrane oxygenation, or ECMO, as well as cardiopulmonary resuscitation. Let's wrap this up with a high-yield fact. A hypothermic patient cannot be pronounced dead until the body is rewarmed to 32 degrees Celsius, so resuscitation efforts should be continued. Remember, they're not dead until they're warm and dead. Alright, as a quick recap, hypothermia is subdivided into mild, moderate, and severe based on the patient's core temperature. Patients with a core temperature between 90 and 95 degrees Fahrenheit or 32 and 35 degrees Celsius have mild hypothermia and should be treated with passive or active external rewarming techniques. On the flip side, patients with a core temperature between 82 degrees Fahrenheit and 90 degrees Fahrenheit or between 28 degrees Celsius and 32 degrees Celsius have moderate hypothermia. Treat these patients with passive and active external rewarming techniques and consider active internal rewarming techniques. Lastly, patients with a core temperature of lower than 82 degrees Fahrenheit or 28 degrees Celsius have severe hypothermia. Treatment includes passive and active external rewarming, active internal rewarming, and extracorporeal rewarming.
Primary headache is a type of headache that is not caused by another condition or injury. The underlying pathophysiology is not well understood, but it involves release of neurotransmitters, such as calcitonin gene-related peptide in migraines, and increased sensitization of pain pathways, including sensory inputs from the trigeminal and upper cervical nerves. The most common types of primary headache are tension-type headache, cluster headache, and migraine. Now, if a patient presents with a headache, you should first obtain a focused history and physical examination, including a fundoscopic exam. History typically reveals a patient younger than 50 years of age who reports episodes of recurrent headaches that are similar in quality and progression and completely resolve between attacks. They also report that the intensity of headaches doesn't require regular use of painkillers. Primary headaches are not positional, meaning that the quality of the headache does not change with positioning, such as when the patient is lying down versus standing up. Also, the headache is not worse with Valsalva maneuvers, such as sneezing, coughing, or straining for a bowel movement, or with jaw movement, such as chewing or talking. While obtaining history, be sure to rule out secondary causes of headaches. First, ask the patient if they have started any new medications recently, because some headaches can be an adverse effect of medications. Also, the patient should report no history of head trauma, systemic symptoms such as fever, malignancy, or immunodeficiency. If any of these are present, think of secondary headaches. Finally, the physical exam reveals a normal neurologic exam in between episodes of headache, with normal appearance of the optic nerves on the fundoscopic exam. With these findings, diagnose a primary headache. The next step is to ask your patient about the laterality of their headaches. If their headaches are bilateral, suspect tension-type headaches and assess the criteria for tension-type headaches. This type of headache can last minutes to days and must meet at least two of the following four characteristics. First, these headaches are associated with a pressing or tightening sensation. Sometimes your patient will describe this feeling as having a non-pulsating band of pressure around the head. Next, headaches should be bilateral and mild to moderate in intensity, but they should not worsen by routine physical activity, such as walking. Finally, Tension-type headaches are usually not associated with nausea, vomiting, photophobia, or phonophobia. However, some patients might present with either photophobia or phonophobia, but not both. If your patient meets these criteria, diagnose tension-type headaches. Management of all primary headaches, including tension-type headaches, should start with lifestyle modifications, such as stress reduction, improved sleep schedule, adequate hydration, and regularly scheduled meals. Also, encourage the patient to track their headaches and use a diary to identify potential stressors and triggers. During an acute episode of a tension-type headache, options for abortive medications include nonsteroidal anti-inflammatory drugs, or NSAIDs, aspirin, acetaminophen, and caffeine. For patients with frequent episodes, consider starting a preventive medication. Options include tricyclic antidepressants, such as amitriptyline, and serotonin norepinephrine reuptake inhibitors, SNRI, like venlafaxine. All right, let's go back and focus on individuals who report unilateral headaches. In this case, you should suspect migraine or cluster headaches, so your next step is to assess whether the headache is associated with either restlessness or ipsilateral autonomic features, such as lacrimation or rhinorrhea. If either of those characteristics is present, suspect cluster headaches and assess the criteria to confirm the diagnosis. The patient should describe headaches as severe, unilateral pain in the orbital, supraorbital, or temporal region that lasts 15 minutes to 3 hours. These headaches are frequent and occur at least every other day, sometimes multiple times a day. Headaches should be associated with restlessness or agitation, causing the patient to pace around or rock back and forth in a chair during an episode, and/or at least one of the ipsilateral autonomic features. These include conjunctival injection or lacrimation, nasal congestion or rhinorrhea, eyelid edema, forehead and facial sweating, and miosis or ptosis. If the patient meets these criteria, diagnose cluster headache, which falls under a broader category of headaches known as trigeminal autonomic cephalalgias. The term cluster is used because patients tend to have clustered headache attacks that last for weeks to months, with periods of remission in between. Interestingly, most patients have a circadian pattern to their headaches, with symptoms starting around the same time each day. Management involves lifestyle modifications. Some known triggers for cluster headaches include alcohol, nitroglycerin, and heat. So patients should avoid these triggers. Acute headache treatment involves oxygen administration and triptans, such as subcutaneous or nasal sumatriptan or nasal zolmitriptan. To bridge the patient until preventive medications kick in, you can use corticosteroids orally or as an injection, targeting the greater occipital nerve. Finally, preventive medications include verapamil, lithium, and galcanezumab, which is a monoclonal antibody against the calcitonin gene-related peptide receptor, or the CGRP receptor. Now, let's go back and look at individuals with unilateral headaches reporting no restlessness or ipsilateral autonomic features. In this case, suspect migraine headaches and assess whether your patient meets the criteria for migraines. Migraines last hours to days and have at least two of the following four features. First, they are unilateral in location. Second, they have pulsating quality. Third, they have moderate to severe pain intensity. And fourth, headaches are worsened by or cause avoidance of routine physical activity such as walking. Finally, in contrast to tension-type headaches, migraines are associated with nausea, vomiting, photophobia, and phonophobia. If your patient meets the criteria, diagnose migraines. Next, assess for the presence of auras. Think of auras as a warning sign of a migraine. They can be alterations in vision, sensation, speech, motor strength, and even level of consciousness. Auras most commonly involve vision, so your patient will usually describe seeing flashes of white or different colors. Also, they might report zigzag lines or a blind spot with a wavy, shimmering border known as a scintillating scotoma. If there are no auras, diagnose migraine without aura. On the flip side, if auras are present, then diagnose migraine with aura. Here's a high-yield fact to keep in mind. Migraines are more common in biological females, and for many individuals, they get worse in the perimenstrual period. Smoking and use of estrogen-containing oral contraceptives increase the risk of stroke in those with migraine with aura. In general, treatment for migraines with or without aura is the same. As before, encourage lifestyle modifications. Triggers for migraines include lack of sleep, strong smells, and dietary items such as chocolate, cheese, and alcohol. Migraine attacks are also associated with menstruation. As far as medical therapy goes, there are various pharmacological options for abortive migraine treatment. Non-specific medications include NSAIDs, aspirin, acetaminophen, caffeine, as well as antiemetics like prochlorperazine and metoclopramide. In the emergency room, a popular NSAID to give is ketorolac because you can administer it intravenously. Migraine-specific medications include triptans, CGRP receptor antagonists known as gepants, a serotonin receptor agonist called lasmiditan, and dihydroergotamine, which is a nasal spray. You should avoid triptans and dihydroergotamine in patients with cardiovascular conditions because they can cause vasoconstriction. There is also a wide variety of options for preventive migraine treatments. Some examples include antihypertensives such as beta blockers and candesartan, antidepressants like amitriptyline and venlafaxine, and anti-seizure medications such as sodium valproate and topiramate. If patients do not respond to these medications or have contraindications to use them, try CGRP monoclonal antibodies like erenumab and galcanezumab, or CGRP receptor antagonists such as atogepant and rimegepant. Finally, for patients with chronic migraines that are refractory to the previously mentioned medications, consider Botox injections, more specifically onabotulinum toxin A. Here's a clinical pearl. Migraines in children commonly involve bilateral frontal and temporal regions. In addition, children may present with childhood periodic syndromes, including abdominal migraine, which is recurrent abdominal pain that lasts hours to days. All right, as a quick recap, tension-type headaches are usually bilateral and mild to moderate in intensity. If headaches are unilateral, consider cluster headaches or migraines, which are more severe in intensity. Cluster headaches are associated with restlessness or ipsilateral autonomic features, while migraines are not. Finally, the management of primary headaches includes lifestyle modifications and medical treatment with abortive and preventive medications.